عصام.
ايوه السلام عليكم. اخوي محي الدين.
Just FYI, we are live on Facebook, so you have a message, you can send it in the chat privately.
Who else joined, Anwar?
You should be able to see them on the screen.
Okay. تمام.
So we're going to ask that if you're not speaking or moderating, you turn your video off.
Hello. Hello.
I don't know who just said hi, but we can hear you.
Hi, Chris.
Dr. Hisha.
I think we all hear, right?
السلام عليكم.
Assalamu alaikum.
صدق عصام هشام كيف حالكم؟
مرحبا.
اهلا بك دكتور.
Thank you.
كيف حالك؟
Dr. Assam is here as well.
نعم أخي. Yes, I'm here.
Chris, is it clear at your end? Oh, I think Chris is not can't hear us.
I'm here.
Oh, okay. All right. What I want is here. Dr. Ali Al-Amrani is here as well.
Ali, I can see Ali.
All right. Okay.
I can see Hisham. I can see Dr. Mahiddin. Dr. Isam.
All right. So I'm sorry for. Well,
Ali.
first of all, thank you so much for everyone for being here. I'm sorry we're kind of facing some technical problem here, but hopefully we'll solve it within like a minute. So for the time being, on our panel, we have Chris, Isam, Dr. Isam, and Dr. Mahiddin is here.
He is here. He just paused his.
Mahiddin parking his car. He just went out from the hospital. He was talking to us with the phone. He will be there within minutes. Dr. Ali Al-Amrani, I'm trying to connect him right now.
All right. And we have Dr. Isam with us already.
Yes, I'm here.
Dr. Isam, Dr. Hisham.
Okay, sounds good. Good.
Dr. Ali
All
will
right,
join
so-
right now. I receive a message. Dr. Ali will join right now.
All right. Do you suggest we? All right. Suggest we will wait for. I'm sorry for the delay. We'll wait for 2 minutes for Dr. Ali. Otherwise, we'll go ahead.
I'm sending him. عليكم السلام ورحمة الله.
وعليكم السلام.
All right, Bismillah. All right, good evening for those who are in Libya, and good morning for those here with us in the US. First of all, thank you for being here with us today. We're very grateful to have you, and we are very grateful to be with you in this critical time. Also, I would like to thank Mumkin for their hard work and making this happen. Well, my name is Musaddiq Habrara, and I am the Executive Director of the Libyan American Alliance. The Libyan American Alliance is a Libyan American advocacy group based in DC that dedicated to promote democracy and rule of law in Libya. However, given the devastating pandemic crisis that we're all going through, we created our COVID-19 response committee led by excellent Libyan diaspora health professionals to help those most vulnerable in Libya. Well, the purpose of today's discussion is to prepare or trying to prepare the Libyan healthcare sector to the onslaught of the pandemic that started to experience a trickle and start to establish a footprint in Libya by sharing maybe best practices and insights from global health community, mainly based here in the US. So today we are planning to have you for about hour and a half, and we will start with brief opening remarks from our panel. Then we would like to receive questions and from the Libya side, in which Rawan, the PR officer at Mumkin, would moderate that session. So without further ado, I would like to begin with introducing the panel. In our panel today, we have Chris Kopik. He's the Vice Executive President at Project Hope. Project Hope, Chris' team actually was in Wuhan a couple of weeks ago, and I still believe they're still there. As a matter of fact, Project Hope, they has been in Wuhan for over 20 years now, where they established a nursing school in which many of the graduates of this school actually were in the front line fighting the beginning of this outbreak in Wuhan. So many, sorry for those. So Chris's team, basically, they were in the frontline healthcare workers in Wuhan, and he have an extensive experience at this work. And also, Chris was in Libya, I think, between 2013 and 2014, where he served with different organizations there.
2011.
Also, 2011?
February, March, and April of 2011. Yes, there
we go.
Very important timing.
From the get-go. Yeah, that was a fun time. Absolutely. Also, Dr. Assam Omeish, he's the chief of the Division of General Surgery at Ainova Alexandria Hospital, and also he's the president of the LAA. And also, Dr. Ali Al-Umrani, he's a senior consultant in infectious diseases at Hamad Medical Corporation. Last but not least, Dr. Muhyiddin Maitig. He's a thoracic surgeon at Mercy Hospital in Cincinnati, Ohio. Dr. Muhyiddin Maitig has been in practice for over 20 years, and he's one of the most excellent doctors in the US in this field. So, without further ado, I would like to begin with Chris and see. Hello, Khalid is here?
Yes.
Yes.
Should I get started then, Musaddiq?
Oh, I'm sorry. I was looking at Khalid. So yeah, Chris, pretty much, could you please share with us what were the main challenges in Wuhan and what are the best practices were made there to mitigate and contain the spread of the pandemic in Wuhan province, and maybe whatever remarks and thoughts that you think we should.
Great.
learn
Thank
about
you.
here.
I appreciate this opportunity, and I'll relay the story of China, but I will defer to our experts here. I'm not a medical expert, nor am I an epidemiologist, so I can share the experience of Project Hope from our vantage point from Wuhan and what we saw in China. But as this virus is spreading, we are seeing different countries taking different strategies and approaches. Not everything that China did is going to be realistic or practical, but I can start by saying China lost time in the first half of, at the second half of December and the first half of January, when they were in denial about the threat of this virus. And that was pretty well documented. And it's kind of common in the case of a new epidemic. Governments recognize that this could be a major threat to their economic interests. They don't want to create panic, and they do what they can to try to quiet the situation. Well, they realized probably around the third week of January, just how significant this was, just how serious a threat it was. And they did a complete reversal of their approach. And we're seeing the same in other countries, United States being a very obvious example of that. And from January 23rd, they started applying countrywide measures to try to contain this virus. And they were very much in containment mode. They did a number of things that proved to be successful, but all of them came with a significant cost. First, they took a aggressive top-down approach towards quarantine and travel restrictions and isolation of individuals, social distancing. But it's important to recognize that they took a differentiated approach. They did not apply it countrywide consistently. They had different measures and different rules and regulations based on the prevalence of the virus within each of those. So my colleagues in Wuhan quite literally did not leave their apartment for 8 weeks straight, whereas colleagues in Beijing and Shanghai had different measures of freedom of movement, but a tremendous amount still of control of monitoring of those movements, regulations about who can go where and what kind of protections they need to take. So they took a differentiated approach, which was really essential to try to ease the pain of these restrictive measures, because we all know that these very restrictive measures can actually do more harm than good when it means crippling the economy, when it means compromising access to healthcare for other individuals, et cetera. So they're always trying to find that balance. So that proved to be effective. In Hubei province specifically, they took extremely restrictive measures where the virus was the most prevalent. They also took a very supercharged approach towards the use of technology. And quite frankly, this is one of those areas where a lot of countries, the USA for sure, is not ready to do, simply because they monitored personal data of just about every citizen in the country. And that meant travel, where they're going, who they're interacting with, what their daily health temperatures are, other symptoms that they may be experiencing. And they would literally give green, yellow, or red tags to an application that every Chinese citizen had on their phone that would designate where they could travel, where they could go, where they couldn't. And if my colleague went on the metro, for example, the subway, and rode on a train, and the day later somebody else on that train was diagnosed with COVID, she would be one of the people that would get a flag, and she would immediately go from green to yellow and would be told to go in and do testing. This is a level of contact tracing and a handover of personal data that is not very realistic in a lot of countries. And not all countries that have been successful in fighting COVID have had to use that. The other area is just the sheer logistics. How do you manage to feed and care for a population of 12 million people, which is what Wuhan City alone is, in terms of delivering food to them and basic supplies? That was really critical. We also know how quickly they scaled up their healthcare. We saw them build 16 different hospitals hospitals is maybe an exaggerated word, but really large scale isolation units almost overnight. Really tremendous scale up there. And they moved 40,000 healthcare workers from other provinces into Wuhan to help address the surge capacity that was needed. So it was really an all of society approach. It was the clinical side, it was the medical side, but very importantly, that public health side. It's getting all of the people to buy into the sacrifice that was needed. And I was on the phone probably 3 or 4 times a week over 2 months with my colleagues in Wuhan. They had good internet connectivity, just talking them through the challenges they're dealing, the mental stress of being stuck in your apartment, literally not being able to go out even into the courtyard there for 2 months straight. And they all maintained a really positive attitude. And it was very much a wartime mentality. Our country is at war. Every one of us has to do something, make a sacrifice, step up and contribute to this battle. And if we don't all do it, and if part of us step aside and think that we're separate from it or it doesn't apply to us, we are not going to be effective. And this process is going to carry on not for months, but for years. And in that way, they were able to really see a dramatic downturn. Within, I think, 3 weeks' time, they went from having about 3,000 new cases a day in Hubei province down to 0. Which is tremendous. Doesn't mean they're out of the woods yet. They have to start easing those restrictions. They have to start seeing if the easing of restrictions is going to continue the spread. But right now, all of the new cases in China every day are coming from outside coming in, not through community-based transmission. And quite frankly, the success or failure of that approach falls back to the ability for diagnostics. You have to be able to test. And that's where South Korea took a different approach. They did not apply the same extremely strict quarantines and some of the same strict measures, but they really went aggressively after community-based testing. And in that way, they also saw a very rapid turnaround there. So the diagnostics is a really critical element, but it starts with leadership. It starts with the whole country coming around to a common cause, recognizing the severity of the situation, recognizing worst case scenarios. You know, as public health professionals, you don't want to create panic. It's the last thing you want to do because panic doesn't help. But you also want to be realistic. And when it comes to taking extreme measures, now's the time to do it. Quick action is required. When Hubei province was quarantined, there were 600 plus positively diagnosed cases. We are seeing countries that are in the thousands now that have yet to take these kind of restrictive measures. And I don't want to hit you guys up with statistics. I'm sure there's more to come from more informed people than me. But one of the more recent ones that I thought was quite telling is it is estimated that for every confirmed COVID death, there are 500 to 1,500 prevalent infections there. The concern from China, from the earliest days of China up through today with COVID has always been what we don't know. We don't know what the transmissibility is of this. We don't know what the R ratio is. We don't know what the fatality rate is. We don't know, how to. We don't know how it's transferred. There's so much that we don't know still about this disease. We're seeing fatality rates dramatically differ from one country to the other. We're seeing transmissibility vary dramatically from one country to the other. And these are the two basic points of data that we have to know to really understand what we're dealing with. So the unknown is still there. We don't know how many people have it. We don't know how many people have it in Libya. We don't know how many people have it in the US. We don't know how many people have it even in countries like China and South Korea, where they have aggressively gone after testing. And we don't know just how dangerous it is to our communities. So that's really why taking quick concerted action that everybody recognizes. It's a whole of society approach. It's not a healthcare issue. It's a threat to the entire population. If you think that maybe you are of an age and a health status that means you're not at risk, and therefore you don't need to worry about it, you absolutely do. Because when a health system collapses because of the number of COVID cases that are overflowing your ICUs and your hospitals, then every other healthcare condition in the country is going to be compromised, and deaths are going to go up dramatically. So I'll pause there. Mossadegh, I'm really eager to hear from some of the other experts that you have on the panel, and then we'll be happy to take questions at any point.
Musaddaq, you're muted.
Muted.
You're muted.
Just so everyone knows, I will be muting everyone while other people are speaking. So just make sure you turn your mic off before you speak.
Sure.
Is Musaddiq on?
Musaddaq is struggling with the microphone.
Okay, I'm here now. I'm sorry for this.
Great.
Well, thank you, Chris, for your excellent remarks, and thank you so much for being here with us today and sharing this great insights. I would just like to highlight that Dr. Hisham Al-Busayfi, he's also he joined us on this panel today. Hisham Al-Busayfi, he's a thoracic doctor, and he's a consultant in pulmonary and ICU at Thoracic Institute for Advanced Lung Diseases and Lung Transplants and Critical Care. Also, Dr. Khalid Al-Aqil, he's the General Manager of Crescent Scientific Trading Limited. I'm sorry I didn't mention your names at the beginning. I thought you weren't there with us yet. Also, could you please introduce yourself as we move to the rest of the remarks? All right. Dr. Assam Amesh, are you there?
I am.
All right. Let's start.
Greetings, everybody. Assalamu alaikum. Thank you, Musaddiq, for this, and thanks for Mumkin for making this happen, and thanks to the panelists who are able to join us today. What I wanted to do is I wanted to juxtapose the knowledge that we have in the US and certainly from Chris's perspective in China and so on and so forth on the Libyan reality. That way we can have a reference as to what is going on in Libya, and meanwhile also utilize the fruits of this discussion so that we can hopefully make the recommendations needed for the improvement of the way we manage or face and defeat this pandemic in Libya, inshallah. I think Libya, unfortunately, is disadvantaged in two respects that are very critical to begin with. One is the fact that Libya still is at war, and there is ongoing warring, unfortunately, in a big area of the country that can make this pandemic even a much more vicious problem facing Libya. Although there is some good measures that are being taken in terms of social isolation and distancing and so on and so forth. But we have to keep that in mind and hope that that will not complicate the issue. The second thing that we have to realize in the Libyan situation is that we're dealing also with a healthcare system that unfortunately has been neglected for really almost a half a century. And it's fairly broken down in its capacity and its ability to handle national emergencies of this sort. However, there is ongoing concerted efforts to create a national initiative that is going on that hopefully will cover some of these emergencies and some of these issues in a way that would allow Libyans to manage this. Hopefully we are early enough in the cycle that we're going to be able to flatten the curve and deal with the problems as they come with a capacity that is being developed that could handle some of these aspects. And inshallah, God willing, we will never get into the situation where we're dealing with the worst, stages 3 and 4 and so on and so forth. Having said that, I think I wanted to summarize the approach that I have seen being done by the government and by the healthcare sector segments through the new initiatives that are being proposed. In addition to, again, in instituting as strict as possible policies of containment and social distancing and isolation, which are being implemented, including curfews and including legislated laws to stop people from gathering and close shops and schools and so on and so forth. That's becoming a reality. Today, Libya, as of last night, we had 10 cases, 9 cases tested positive. 1 case has in fact recovered, and there's no deaths so far Of course, we're way at the beginning of the curve, and again, God willing, we won't see an extension of those numbers. But what they did beyond the restrictive policies, now the talk is about preparing the country for how to manage the problems as they arise. There is a project, or part of the strategy is to create centers for containment, where rooms are being prepared in different centers. And the goal is to have 11 of these centers across the country, where each center has a certain number of beds, hopefully in proportion to the demographics and the density, where they can receive these cases, they can do some testing, they can do some management because of the panic, because of the fear of managing these patients in public health facilities, which are already undermined, unfortunately. And we've seen an unfortunate example with the first patient, but things are getting better with the second and third and so on and so forth, of these patients. So first is these containment centers in different parts of the country. Second, they are working on developing what they call the mobile physician. They're training 100 physicians with vehicles, communication skills, and abilities to hopefully protect themselves, hopefully have diagnostic tools initially, at least, maybe the rapid test, maybe an ability to get a blood sample, get the samples that are needed, and collecting the samples as needed, in terms of being able to do the PCR testing eventually, and so on and so forth. These 100 physicians, their role is to, through a centralized number, through an emergency plan, be able to respond to the areas where there are suspected cases. So anybody who's running a fever, got a cough, any concern, instead of them going to the public health facilities and risking the potential for possibly infecting more people, they can call the hotline and these people will come to them and test them. So this is being implemented as we speak, and hopefully they will get their capacity up to speed in due time. But this is being put into place. There's also some preparations with the major centers, especially what we call Markaz Tarablus al-Tibbi, the Tripoli major center, so that at least they have some facility, because no matter what you do, some people will eventually end up going to these public health facilities seeking help. So they're trying to prepare them for preparing the infectious disease, groups and the other nursing groups to be able to handle this. Again, this is unfortunately relative to the breakdown in the healthcare system, so it's hard to assess whether it's going to work very well or not. Then there is the issue of testing, and so they're gathering national capacity, their national reserves. The talk is that there is about 30,000 rapid test kits available that they can use in order to test, for larger numbers. But they also have the PCR machines, the RTs, the reverse transcriptase polymerase chain reaction, the PCRs. They have what's called the gene expert PCR machines. And so what they're saying at this point is that they have a couple of these machines in Tripoli. They have one of these machines in Misrata. They have one of these machines in the south, but they are procuring 22 total PCRs that they think are coming. Sorry, 3 in Tripoli, 1 is in the south, and the east, they're not exactly sure how many because of the political divide that's there, but there is actually some preparations that are taking place in the east of Libya. The south remains one of those areas, unfortunately, where no matter how much you will do initially, I think the breakdown in the healthcare services is extremely terrible in the south. So that's the testing. Hopefully will be up to speed. I've heard reports and I've seen and I've spoken to some of the physicians who are responsible for some of these activities. And despite the cost involved, or despite the waste that may become involved in testing only 1 or 2 cases, they're being very diligent about testing every possible case. And they have tested far more than the 10 that were positive. And so far, these are the numbers. Not the last thing, but another aspect that I will talk to is in terms of in case of escalation of the capacity of the disease process. Of course, you're going to be dealing with the more critical, patients, some of them who will need to be accommodated in hospital facilities. And of course, the few of them are going to be the ones needing intubation and ventilators and certainly intensive care unit specialties. right off the bat, if we're looking at the numbers, and this is not easy to predict, but this is where Chris and people who have expertise can help weigh in. But Libya roughly is about 7 million in population. If we take the more conservative, more hopeful numbers, or at least less numbers, we're talking about maybe 1 in 1,000 that will be infected, tested positive. So we're dealing with about 7,000 cases. Of those, about 5% will end up being critical patients. So you're talking about 350 patients, and about 6,650 cases, which will be sick enough to warrant maybe hospitalization, but hopefully not sick enough to warrant ICU care and ventilator capacity. If you look at these numbers, then you're talking about 350. They're being hopeful by proposing that they will go as far as preparing 500 ICU type beds with ventilators. The problem, of course, is this is more paperwork and wishful thinking in some ways, because of the fact that the capacity needed to run these ICU beds, whether it's doctors who have advanced training, or whether it's nurses that are more specialized, or whether respiratory care therapists, the equipment that you need, the maintenance that you need with the IVs and the arterial lines, and the extra care that comes with caring for a very critically ill patient, it's very difficult to predict a positive, hopeful capacity that way. And the last that I will talk about is the fact that we need the equipment needed in order for us to protect the healthcare providers, as well as to be able to engage this pandemic in the safest way possible. We don't want the doctors and the nurses and the healthcare professionals to become the victims of the lack of personal protective equipment and gear. And in that, it's really, the numbers are not very clear, but they're, the capacity for disinfectants and the capacity for gowns and masks, and certainly more advanced, masks, the N95 or something along those lines, is all, I think, in limbo. I don't think we have the numbers that we can deem good for a surge or for a capacity that becomes possible. So all in all, I think one of the significant recommendations of the doctors outside is we have to concentrate our efforts in the first couple of stages of educating and social isolation and flattening the curve far more beyond dealing with the potential surge and the potential dramatic cases, because most of my colleagues on this call, people who have spent time in Libya, people who have much more experience than I spent most of my time in the US. But the fact is that they know that the healthcare system in Libya is deeply detached and deeply fragmented, and potentially it could be very dangerous if that happens. I hope we can match those capacities, and I hope as Libyan American physicians, we can continue to lend support to the process as we move forward. And with that, I will listen to my colleagues' comments. Thank you.
Before we move on to someone else, can we just give a chance to the Mumkin folks and the CDC folks to introduce themselves?
Hello, hi guys. I didn't want to interrupt the ongoing discussion. I would like to thank everyone here for coming here and sharing their experiences. I do think, I'm not trying to be gloomy here when I say that we're probably going to a very critical situation here in Libya with the lack of preparation and the general panic building up here. So we thought this approach would help us prepare in terms of understanding experiences and sharing what you guys have gone through while facing this pandemic in your countries, and try to shed some light on how we can handle it here in Libya. As Dr. Issam Ramesh kindly said a minute ago, is that we're talking in terms of numbers here, and just a small calculation will show you the amount of preparation we should be doing right now, which is we will put efforts into doing that, but eventually there's limited access to actual preparation here in Tripoli and in Libya in general, knowing that there is a state of war and terribly misengagement between the people and the government trying to work and establish these things. So this approach was more than just sharing experience, more than just talking about it. We're just trying to put bases for something that could actually reach out maximum people and help out. Me and my friends in Team SPAR, who was strategic preparation and readiness, what we're trying to do here is to create some form of protocols to help not just the medical staff, but also the normal people into handling the pandemic once it reaches the scary numbers we are talking about. Hopefully it doesn't go crazy wild. Hopefully this will be contained by awareness, by people trying, and this is what this is all about. I would like to thank everyone here, and I'm giving the mic to the next one. Who's next in the discussion panel?
All right. My name is Aladdin. I work for Mumkin, and I'm the coordinator for this project, if we can call it. I'd like to firstly thank everyone for showing up and for attempting or for giving effort to aid us during this pandemic. As my colleague and as the previous speakers have explained, the current situation in the country is that there's a huge gap and a huge lapse of communication between different parties, and it is almost difficult or impossible to rely on government officials to organize a group effort or unify some sort of protocol or to come up with guidelines that will be unified. Our attempt here is to sum up the experience of other countries in facing the pandemic and to modify them to match or to go with the Libyan situation and come up with something that is feasible to apply. We know it's a huge task. It's probably something that many other countries are struggling with, but we want to do our best to encourage our doctors, to give them the knowledge that they need, and to give them some sort of ability to assess their situation, to be able to react and do something without endangering themselves. Also, we have with us Muad Muntasir. He's the program manager for Mumkin organization. I would like to pass the word to you, Muad.
Is Muad there?
Why don't, if it's okay, just for time purposes, can we?
Yeah, just
go
proceed with the
back
next
to
speaker.
our doctors.
Yes.
Yeah.
Hello, everyone.
Kidding.
Let's go ahead to hear from our panel. Dr. Hisham, are you there, Pusefi? Would you prefer to go ahead? Okay. We don't hear Dr. Hisham. Dr. Hisham, you're in mute.
Let me.
Yes, great.
Okay. Now
I muted him. We're good.
Assalamu alaikum, everyone. I was listening to Dr. Isam introduction about what is the plan that Libya had already in place. Trying to contain the spread of this virus, and also they created a mobile physician group that they go to the patient and try to come up with diagnostic approach to find out the patients who are infected with this virus. Number three, also they try to prepare the big hospitals in the country, but mainly he was talking about Tripoli Medical Center. I didn't hear any other big hospitals in the country are prepared for to try to manage this problem if it gets bigger. Number four, there are 500 ICU beds, and also trying to get the protective equipments for the physicians or the healthcare providers in the country. So I like all this plan, but I have some concerns here a little bit. And number one is, I think, for Libya is a little special case because the resources are limited over there. And I believe that the focus should be on the to answer the question of how can we prevent or limit or slow down the spread of this infection. So if we rely, so how can we do that? Number one, if I want to rely on the test, maybe I will, because here is the problem with the test. Number one, you have a maybe technique problem, collection problems that you may face, and you get false negative results, and that could confuse you and make you not able to identify all the cases. The sensitivity of this test itself is not 100%. We know this is there is limitation for this test sensitivity, which is probably around 75%. I know there is another test came out, which is it takes like 5 to 15 minutes to give you the result, but I don't know how much is the sensitivity of that test, and I believe that's not going to be 100%. So the test itself has an issue. So what should we do? I mean, I believe that if we rely on the approach that by what is the clinical syndrome of the patient, if the patient has clinical syndrome that's suspicious or mimicking symptoms of the coronavirus symptoms, then that patient should be considered as possible, or at least coronavirus or COVID-19 infected patient until proved otherwise. Okay, so how should I approach this patient, or how can I identify this patient? I believe that maybe this mobile vehicle that with them taking the physician to the patient, this could create a problem. This could transmit the disease from place to another. So if they are not careful, I'm not sure if they'll be very, very careful, because even inside the hospital, sometimes we have a problem is how can I, take care of, manage the removal and putting on these PPEs and controlling the spread of infection. So that's another issue. So I believe that if we try to create a mechanism to identify the patient with just a clinical syndrome, without imaging, without testing, okay, and I triage these patients to either to stay home or to come to the hospital or another place where I want to test him, or I want to admit him, or I do some further work. So how can I do that? I think if we create, because if we create hotlines to everybody in Libya, okay, so all these hospitals, all these clinics, or they become hotlines, or the private sector, the public sector, they have phones, they have volunteers there, physicians, they will be answering all these phone calls, and he will take that phone call and listen to the patient. The patient, he will tell him, you know what, I have symptoms, and if those symptoms are suspicious for COVID-19, then the physician responsibility is to triage that patient, whether to stay home and isolate himself and give him instructions to how to help him to contain this virus and stay there. And he doesn't have to tell him you have COVID-19, but he could tell just you have a cold symptoms, and this could be COVID-19, but we want you to do the following, and he gives him the instructions. If he believes this patient requires further work because this patient could be sick, he could be short of breath, and he hypoxic, and he needs further management, then he will ask him to come to certain places that you mentioned. You said we have 11 centers in the country that they are designed to help with the isolation and management of such cases. Okay, so that is the triaging. I think this is good mechanism, but taking the car or this vehicle to go to the patient, this could be a problem. I'm not saying this is wrong, but I have a concern there. Then if inside the hospital, that patient, I have the capability there to test him, to do chest x-ray or to do CT scan. to do whatever there. And if I believe this patient is, COVID-19, I should continue isolating him regardless if the pretest probability is high. I should not rely on this test because I see problems. I'll tell you, I see problems in there in Libya that the test is not good idea to rely on this test. You could use imaging plus the clinical syndrome, and if both are positive, then you should manage that patient until he recovers from this illness as COVID-19. So that's the mechanism I see at this point that may help the country to limit. I cannot say prevent because we have already cases outside already, but at least limit the spread of the virus. And even if the virus starts spreading, it will slow the curve of the spread of this virus so the hospitals cannot be overwhelmed. I give you another thing that I try to do some work in one of the local the cities or the towns there in Libya. I have been working with the Medina Sorman city. I'm originally from Libya and also Sorman, so I try to help them, and I'm trying to do this there. And I think I'm in the final steps now to achieve this goal in Sorman. We have a place where we have like good, at least 10 ventilators in that place. We have a good number of beds, maybe 80 beds there in that city, which is, I believe, maybe it's a 100,000 population in that city. So we created these hotlines. All the private clinics become hotlines. You respond to any patient who have suspicious symptoms or any cold symptoms or fever, or he called this line and he will find a physician there ready for him to answer the call and triage this patient, whether this patient has suspicious symptoms. He stay home if he's doing fine, and he reassure him. And if the patient require further work or he seems to be sick, then he'll ask him to come to that particular place. He doesn't ask him to go to any other place outside Sorman city. And there we continue to manage him. The other thing that I wanna also add, I think all the elective work in the country has to stop. Means what? Somebody needs bronchoscopy or a colonoscopy or any elective surgery, elective procedure in the country has to stop, because this can spread the disease itself, and at the same time can take the resources away from you. You want to spare all these resources in the country to fight this crisis now. So no visitation inside the hospitals or private clinics. So all the work, the elective work inside the public sector has to stop. All the non-emergency work in the private sector has to stop. You leave only ERs working there. Somebody with acute appendicitis, he can go to that place and get help. But somebody with low back pain or headache or diabetes management, that patient, this is not the time to take care of that problem. That patient should stay home until 2 or 3 months from now, so we can at that time we will be able to help him. I think this is the at least the highlights of what I think about how can we at least start with this problem. Later on, when you guys talk about the management inside the hospitals or how to manage patients with ARDS, or whether the medication that they use outside in the these new medications, if they are effective or not, we'll talk about later on. But I think the focus should be here, to identify the case, the infected person, or at least a suspected case, and separate that case from the society, from the non-infected people. If we focus somewhere else, we will lose the game. We have to focus here, and we need to find a mechanism, the best mechanism that can be applied in Libya that help us to do this essential and the most important step to control or slow or limit the spread of this infection. And now, thank you so much for allowing me to talk. And yeah, I'll allow my other friends to take the opportunity.
Thank you so much, Dr. Hisham, for your excellent remarks. I just shared, by the way, I just shared a link from the CDC where they recently published a package of information for healthcare professionals, which pretty much covers all aspects of how we respond to the current pandemic. Speaking of which, I would like to ask, do we have anyone from the Libyan National Center for Disease Control with us? And CDC?
Yes, we do. We've got Dr. Kamal Tallour. He's listening right now.
All right. I suggest maybe we hear from Tallour and then we continue with our panelists. Does that sound good for everyone?
Yeah, sure.
All right.
تفضل دكتور.
السلام عليكم، مرحبا، كيف حالكم؟
عليكم السلام ورحمة الله.
عليكم السلام، مرحبا.
دكتور كامل تلوع، مكتب طوارئ صحة المجتمع من المركز الوطني لمكافحة الأمراض. كلكم تكلموا عربي ولا حتى بيسمع؟ Is it okay?
We only have Chris, whose Arabic is pretty basic, I guess. But
maybe we can speak in Chinese, Chris.
All right. So, Dr. Islam, would you be able to maybe summarize and translate to Chris later? Is that...
No, it's no problem. Please, by all means, speak in Arabic. And colleagues, I do have a hard stop at 12, so forgive me for that. But I've really been enjoying this conversation. So please continue in Arabic. Don't worry about me.
All right.
It's okay. It's okay. I can speak in English if you like. But anyway, the situation in general is not good. It's not too bad as well. You know, we are all new to this this COVID problem since it's elapsed probably a week or so in Libya. That's when the first case was confirmed. Few weeks before the case diagnosed, we were preparing for such a thing, but as everybody knows, I think we're very short of kind of spaces and equipments and also the manpower as well. And even though we're not very well expert to face such a problem, because it's the first time we face a pandemic problem in Libya as the other people. In CDC, where I'm working at the moment, we are trying, we have already implemented a very good, well scientific plan, and we try to get communicated and to communicate with the old sectors who should take the responsibility with us, every ministers. We have a high committee now, the Minister of Health, Minister of Health is the chief of that committee, and every, I think, minister should take their own responsibility, as I have told you already. As I said, we're still short of equipment, short of facilities to diagnose or confirm diagnosis. We still need more experience, and we need more consultations and training in terms of how to deal with the disease itself. So
I'm sorry, Doctor. Would you mind? I would like to interrupt you here for just a second, since Chris is leaving, and you mentioned the capacity building and the need for training programs. Chris and I, we had a conversation where Project Hope they were developing a training package in English. So maybe we can, Chris, is the training curriculum is already in place, or are you still working on that?
Yeah, I'll speak to that quickly, and then again, forgive me, I'll have to sign off. But we have worked with Brown University to develop a training program targeting frontline healthcare workers. So it's about 10 different modules. It covers screening and triage, case management, treatment protocol, but it also incorporates things like risk communication, healthcare or hospital level surge staffing. It's very comprehensive. We just delivered the very first one in Macedonia. It's being delivered via Zoom, and it was extremely well received. They're taking in some of the feedback, trying to add a few other modules that were requested. I'm trying to think of what a couple of those were. And then once that's finalized, we will make this publicly available. So maybe Musaddiq, through you, I can share the link with how to access that. We haven't translated it into Arabic yet, but maybe that's something that the Alliance could look into. But otherwise, very happy to make that publicly available.
I'm sorry to interrupt here, but the same project we're working on is working on something very similar. We're working on creating a series of protocols. It's basically what you're doing. We're going through a set and series of steps you take to identify, diagnose, and then treat, and go on with the procedure of handling the cases who are infected with the COVID-19. So maybe we can collab on that, because we're already starting. We're somewhat halfway there. Maybe we can compare curriculums and come up with something in between, because what I'm worried about, and what everyone has been mentioning ever since the start, is that Libya is a little bit different in terms of preparations and in terms of training. It's very difficult to make sure the equipments are there. I'm just thinking that in all the material we've gone through to create the protocols we're working on now, they talk about okay-ish situations, like sometimes in Libya, you wouldn't find basic equipments, therefore you cannot proceed with the same protocols. What we want to develop here, and where we want to go with this conference and in this discussion panel in particular, is to come up with something that can be applied here with the circumstances, with the difficulties, and with the lack of A and B and C. So maybe we can try and use your material, but try to make it more realistic and more applicable here.
Yeah, so a couple points on that. Firstly, the training was designed for lower resource environments. There's no training around how to use an ECMO machine, because most of the countries we're going to be delivering this will not get to that stage of treatment. That said, the materials will be available to you, so you can compare them, you can use them as you need, you can modify them as you need. It's really, to be there, it was based on WHO protocol. So hopefully, if nothing else, it can save you a little time and energy in pulling these things together. But it's really just a resource to be utilized.
Brilliant.
Nice, that's very great. I'm sorry to jump in. Mr. Chris, how soon do you think the material will be available?
We're hoping, where are we? Wednesday? I was hoping by the end of this week, but by next week for sure.
Guys, we can connect you guys also.
Yeah, we'll keep in touch.
Lovely.
But let's maybe get back to our
Chris, thank you so much for being here with us. Thank you for your time. We will stay in touch. And we
thank you all.
Thank you. Thank you.
Good luck.
Thank you.
All of us.
All right, so let's go ahead with our panel. I think Dr. Muhyiddin is also. Is Dr. Assam speaking already? Dr. Assam, you're in the mute. I'm sorry.
He hasn't finished his presentation.
يا مصدق خلي دكتور كمال يكمل.
I'm sorry. Let's go back to Dr. Kamal.
شكرا.
I'm sorry.
ايوه. فخلاص لو نقدر ناخذ راحتنا اكثر ممكن نتكلم اوكي.
جو هذا بالعربي ان شاء الله.
الاستعدادات. في اطار الاستعدادات يعني كمركز بادل قصارى الجهد الحق يعني الامانه ما هي، وقلت لك واضعين خطه شامله لكل القطاعات هذه، والخطه نزلوا بها على مستوى البلديات، وكل بلديه طبعا بتشكل غرف زي غرف العمليات الخاصه بها، غرف ازمه، وتشكل فرق عمل وتشتغل عليها. تواصلنا مع وزاره التعليم ايضا، حتى هم مكاتب التعليم كلهم على مستوى ليبيا طبعا الشغل احنا نشتغل فيه هذا. نحاولوا ان احنا نوحدوا الخطاب ونوحدوا الجهد، ويكون المين ريفرنس في الشغل هو CDC، والاكزيكتيف يكون وزاره الصحه. طبعا لازم يكون في تعاون من الناحيتين. المشكله الحقيقيه اللي تواجه فينا الان اللي هي الميزانيه ما زال ما صرفتش، وفي شورتج في كل شيء. يعني مثلا على سبيل المثال اليوم كنت مع highly suspected case، وانا في طبعا a lot of controversy we should discuss it later. باهي بالسيتي سكان لما درنا له سيتي كان لي highly suggestive to be COVID-19. طبعا البروتوكول او الجايد لاين يقول ان احنا we should confirm this or take it further and do a PCR. فالى اللحظه هذه قاعدين ما عندناش حتى سواب. we run out of swabs, we run out of kits to diagnose, we run out of almost everything before we even kick off. I think واحده من الاسباب طبعا لان بعض البلديات they took a step forward before we should do that. يعني على سبيل المثال هم ركزوا لي على سيارات الرش ورش الشوارع وما الى ذلك. هو في الحين اللي ما زال اساسا ما خشش، قاعد الكوفيد ما خشش ما زال الفتره هذيك. باهي قاعدين يركزوا لي على مواضيع التعقيم which is useless يعني from the point of control infection control point of view useless. يعني التعقيم هذا كله اللي يشوف فيه في الاماكن العامه والشوارع وما الى ذلك. ففيه waste of resources وفيه miss distribution للريسورسز I should say. باهي نحاولوا نعدلوا في او نحاولوا نديروا implementation ل more strict rules which everybody should follow. باهي مشكلين زي ما قلت لك لجنه عليا متكونه من وزير الصحه كرئيس للجنه، ومعه وكلاء الوزارات، وفيهم مدير المركز مدير عام المركز عضو في اللجنه هذه. ايضا درنا طبعا اقترحنا ان يكون عندنا لجنه علميه استشاريه من سبيشالتيز زي الميكروبيولوجي، اللاب، الفيزيشنز، الانتنسيفست، ودرنا الان لجنه علميه. باهي حاولنا نديروا مكان للايزوليشن على الاقل تو ستارت اوف ويد حتى سمول سبيس around Tripoli. طبعا very difficult. most hospitals refuse the idea وانا I totally with them لان ما عندكش alternative. لما تاخذ مستشفى بتديرها for isolation السيرفيس اللي كنت تقدم فيها في المستشفى هذه وين بتقدمها؟ البرايفت اولموست كلهم مسكرات، يعني العيادات المستشفيات اساسا معدودات في طرابلس. فحاليا واخذين مجمع زاويه الدهماني، اعتقد كلكم تعرفوه. باهي فحيكون as a place for isolation to start off with، وفيه زوز اماكن ايضا في طرابلس يحضروا فيه. يعني الشغل ما زال ما هوش very well coordinated هنا ولا very well ما فيش good communication، ما زال قاعد فيه مشكله. اعتقد هم توا حاليا وصلوا لقناعه ان اللي المفروض who should take the lead اللي هو المركز الوطني لمكافحه الامراض انه one else and they should follow his instructions and protocols في الموضوع هذا. فاليوم قاعد نستنى طبعا في اجتماع حاليا في اللجنه العليا حتى هو باهي نشوفوا شو بيقرروا. انا مش عضو في اللجنه العليا، يعني انا مدير مكتب الطوارئ نفس في المركز، ولكن نحضر احيانا في الاجتماعات يعني واحد 1 باي 1 مع مدير المركز ونشوف شو يصير. للان الحمد لله it's contained, everything is okay, it's all right. ما فيش سبريد as per se سبريد يعني ولا هجوم كاسح هيك صار بالفيروس. باهي even though I shouldn't say انه ما فيش حالات، لان احيانا في موجودات mild or asymptomatic or whatever. باهي لكن على الاقل ما صارش الاوت بريك اللي صار مثلا في ايطالي ولا صار في فرنسا ولا صار في مكان ثاني. وهذا واحده من الاسباب. يعني I should proudly say ان الشعب استجاب يعني للانستراكشنز والتعليمات هذه ايفن حتى بيفور انهم يقولوا فيه كيرفي ولا حاجه. الناس يعني قلت الحركه هلبة، والناس خافت اكثر من ان هي يعني التزمت. باهي تحاول ان هي فعلا ادركت حجم المشكله وشافت العالم شو صاير فيه، وعارفين اللاك اوف ريسورس هنا والشورتج اوف ايفريثينج. فعارفين انه لو بيتفشى لا سمح الله الفيروس هذا ما فيش ليه حل. يعني كل واحد يستنى مصيره وخلاص والله اعلم. فزي ما قلت لك قاعده ما زال فيه شويه فوضى، خلينا نقول لك بالضبط في المشهد باهي، لكن لعل في الفتره القريبه هذه تولي وتتنظم. عندنا مشكله ثانيه طبعا، الناس اللي قاعدين خارج ليبيا، عندنا جاليه كبيره في تركيا وعندنا جاليه ثانيه في تونس، حتى هي هذو المين، لان حتى اللي كانوا برا في اوروبا وفي مكانات ثانيه لازم ياخذوا ترانزيت يا في تونس يا في تركيا. خشوا مجموعه منهم كبيره، لكن الان موجودين الحصر بتاعهم حوالي في من 2000 ل 3000 في قاعدين في تركيا، وممكن نفس العدد او اكثر او اقل في تونس حتى هم قاعدين. طبعا كونتاكت مع وزاره الخارجيه غادي يكلموا فيها على اساس بنديروا اليه كيف يخشوا وبيرجعوا كلهم. طبعا ما تقدرش بترجعهم هيك هازاردلي، لازم تكون حاجه فيري ويل ارينجد، وهذا علاش انا حلت الموضوع اللجنه العلميه هذه باش تحط لنا جايد لاينز وتحط استراتيجي كيف نروحوا بهم بحيث ان هم يكونوا سيف والمواطن يكون هنا سيف. فهل بيديروا لهم مثلا بي سي ار سكرين كلهم؟ هل بيديروا لهم سي تيز؟ هل بيروحوهم هنا على الكورنتين؟ هيديروا لهم ايزوليشن؟ المهم بتشوفوا لها من عده جوانب، لان ما غادي فيري ديسبرت انهم يروحوا وقالقين، وحنا هنا ما عندناش الكاباسيتي والكابابيلتي ان احنا نستقبلوهم ان وان جو. فهذا الوضع حاليا في ليبيا. لو في حد عنده اي استفسار ثاني ممكن يذكرني ونجاوب.
شكرا دكتور، بارك الله فيك. ثانك يو سو ماتش. عندنا ممكن اخر بانلست معانا الدكتور محي الدين، وممكن بعدها نخشوا على مساله الكيو ان اي او نستلموا اسئله واجابات ان شاء الله.
We also have دكتور العمراني.
الدكتور العمراني معنا ايضا صح؟
والدكتور العاقل حتى هو
خالد.
اوكي، احنا لنا الوقت يداهمنا حقيقه. ف alright, دكتور محي الدين is here. دكتور العاقل, who's gonna go next? So we can go out with Q&A after, as long as we. All right. Okay, so let's go out the Q&A and.
I think Dr. Mahi said he was going to speak.
All right, I'm sorry. Okay, Dr. Mahi Eddin, floor is yours.
I'm not taking a lot of time from anybody. I think without knowing الخط or the roadmap from the NCDC of Libya, it's very difficult to come with another roadmap and try to implement it. So number one, we need details of what's the roadmap from the NCDC, if they have one. So it's all come down to Dr. Kamal, if he could feed us what is the protocols. If the patient have fever at home, who he should call, where they should be there, because all of the people sitting around, we could come up with a lot of roadmaps. As Chris mentioned earlier, each country deal with this differently. NCDC is our guideline. So to not waste a lot of energy, we need to know what's the NCDC or guideline or direction. Are they thinking about isolating everybody at home, isolating people to those service center, or sending the physician? So we need to know, and it's got to be simple, because otherwise, simple means if the patient called from his house, I have a fever, to the hotline, if there is a hotline. What's the direction from there? There is a physician going to go to him? If there is a physician going to go to him, he needs to be appropriately trained, and we should work on the training on how to glove and deglove. I mean, it's not only wearing the goggle and the gown and the gloves, it's how to take them off when you go from house to house. Where we're going to dispose that material, how we're going to prevent what Dr. Hisham just mentioned, spreading the infection by that mobile physician. Now, if you guys decided to do a different route, and you said, okay, if the patient called with fever, we're going to triage him over the phone, like Dr. Hisham saying about Surman. And if the patient is not desatting or he doesn't have a reason to be in the hospital, we're going to tell him to quarantine himself for the next 14 days or until he improves, and somebody will check him at some point. And if he desatted, we will transfer him to those isolated center. That's a different story, because we need to know who's going to transfer that patient from his house to the isolation center. Is it his family? That if we do that, that's a problem too. So we need to know what's the CDC or the NCDC in Libya roadmap, so we could help to advise where is the problems or where you could have the problems, how to manage the issue in general. We all understand is isolation, isolation, isolation. Once you get to the hospital, another isolation, and now you have to protect the health worker. And you're going to reach a point, unfortunately, in Libya, with all of my due respect, I worked there for 2-3 years, and I know we don't have enough critical care physician, and we don't have enough critical care nurses. So those imaginary number of 500 ventilators, that they will not manage themselves. So they don't work. That's not going to work. So, but with all of this said, we need to know detail of the NCDC roadmap so we could help of tweaking that map or supplement that map to make it work. Otherwise, we're going to have 3,000 roadmaps, and we're going to be working against each other. Not against each other with an intention, without an intention. But everybody have his own opinion. And right now, I think the NCDC, if they are on charge, they are on charge. So I would love to hear from Dr. Kamal at some point what's his roadmap. Unfortunately, I do ECMO, and we are so far away from ECMO in Libya. So, and actually, we don't have the machine to begin with. So, but that's we go back to utilization of resources. In Libya, you have a limited resources. You have to be thinking about those 5% that you're going to put on the vent and utilize significant amount of resources, or this 15% that you could help with oxygen and mask and symptomatic support. And if you have the choice, what you're going to choose. I wish if I can choose all of them, but sometimes you're going to be in a very hard spot to choose whatever it is that right for the country. So I would love to hear what is the roadmap from the NCDC, and that's something they should share with the public. So the public have to understand that too. Because when everybody know what is the roadmap, they could play a game. Otherwise, everybody is pulling from his direction, and it's not going to help. Thank you.
All right. Thank you so much, Dr. Muhyiddin Maitig, for highlighting this crucial element of how to manage the pandemic crisis. I believe also that the NCDC maybe should develop a guideline and clear protocol of what healthcare professionals should know about caring for patients with confirmed or possible COVID-19 infections, and with a clear strategy that could be accessible for public as well. So we will go ahead with Dr. Ali Al-Amrani, if he's still with us, before we go after to the Q&A session.
Yes, I'm still here.
Dr. Ali, please, the floor is yours.
I don't think I've got anything specific to add to what I've just heard, but I'm quite happy to contribute to any Q&As later, I guess.
All right. Dr. Khalid العاقل, you want to
مصدق. اولا السلام عليكم. السلام عليكم جميعا. كيف حالك كامل؟ في زي ما تفضل الدكتور، انا بتكلم باللغه العربيه، كلنا هنا موجودين تقريبا موجودين بالعربي، تمام. عندي شويه استفسارات، وفي نفس الوقت بنأكد على الكلام اللي قاله الدكتور محي الدين مايتيج. ما دام ما فيش ماستر بلان، ما فيش استراتيجيه واضحه الاخوه في ليبيا، ما نعرفوش احنا كيف نديروا contribution و collaboration. لابد نكون في ماستر بلان، تكون استراتيجيه واضحه. حتى نقترح ان يكون عندكم على الاقل كل يوم 3-4 دقائق توضحوا شنو درتوا وشنو تبوا تديروا، عن طريق الاعلام، عن طريق الكلوزد جروب، عن طريق ايميلز اتليست، باش نشوفوا احنا where we can fit where we can help في التريننج، في الاشياء الماتيريال اللي ناقصه، في الراي، في الاستشاره. الاستشاره تختلف مانجمنت ولا تقديم استشاره طبيه من الاخوه اللي موجودين في امريكا او في قطر او في بريطانيا لاجل دعم المسار نتاعكم. انا نبي نعرف بس، انا سمعتنا في 2 كوميتيز. الكوميتي الاولى هي حسب ما فهمت منك يا كامل كوميتي CDC كوميتي نتاع ليبيا، وفيه مجموعه تجتمع في مجمع زاويه الدهماني اللي على راسها دكتور عبد النبيل رايس. هل في حد من المجموعه هذه موجود معنا حاليا؟ أنا اسمعش فيك، انت ميوت.
I think Rabia could advise on that aspect.
Okay.
شكون دار ميوت؟ قلت لك الكلام للجميع. تو نوضح لكم من ديتيلز يعني شنو فيه بالضبط وبالتفصيل. باهي مش حناخذ وقت هلبة لو الوقت يسمح يعني. انت تعطيني الكلمه توضح لك بالضبط. You know where you fit yourself.
ايه لان تو زي الدكتور هشام، زي الدكتور علي، وزي الدكتور محمد والاخوه الاخرين الكرام، دكتور عصام، ما دبينا نعرفوا بالضبط شنو عندكم من اجراءات مدايرينها وشنو محتاجين بالضبط على اي سايد، وهل انتم حاطين استراتيجيه ان بليس ولا لا، باش نقدروا نعرفوا احنا وي كان فيت وي كان هيلب. تريننج، مواد طبيه، تدريب عن طريق اونلاين. فيا ريت كامل ولا الدكتوره راويه تعطينا الاستراتيجيه اللي عندكم.
ايه بالنسبه للمركز فيه لجنه تسييريه اللي ما يخص المركز نفسه، لجنه تسييريه فيها الدكتور بدر الدين وفي الدكتور عثمان والدكتور العربي من فوق، ومنها تتفرع لجان لجنه اعلام، لجنه تثقيف، لجنه توعيه وما الى ذلك. احنا مثلا في لجنه التدريب والتوعيه والتثقيف، انا والدكتور محمد العزيبي ومجموعه دكاتره معنا. باهي الفتره هذه كلها مركزين الافورت على التوعيه وعلى حكايه التريننج، بالخصوص طبعا عندك تريننج الميديكال والباراميدكس، وعندك الامن، وعندك ايكونوميك كاتيجوريز. فهمت؟ ماشيين فيه ان شاء الله، في تريننج حتى على انفكشن كنترول وما الى ذلك. باهي بعدين فيه كوميتي ثاني اللي احكي لك عليها، الهاي كوميتي. هذه اللي طبعا انا نشوف فيها اخرت الشغل وما خلتناش نخدمه، لان تو لها حوالي اسبوعين اجتماعات جاست ويست اوف تايم. هي كلها الفكره ان هم كيف كل واحد ياخذ نصيبه من الهاف بليون هذا. تو بي فرانكلي اونست معكم. باهي ان تيرمز اوف جايد لاينز، موجود عندنا جايد لاينز احنا في ال CDC. باهي ومينلي وي ادوبت ال WHO جايد لاينز. باهي والامبلمنتنج اون ذا جراوند طبعا يعتمد على الفاسيلتيز نتاعك، من شو انت تقدر تدير. يعني عندنا الكاتيجوريز نتاع السسبكتد كيسز، وعندك الكونفيرمد كيسز مثلا، وبعدين عندك كونتاكتس سواء كلوز كونتاكتس ولا اي كونتاكت بعدين انت مشتبه فيه. فحاليا ما عندناش امكان سبيسيفيك فور ايزوليشن بير سي، قاعدين في امكان يجهزوا فيه. باهي واحد منهم بزاويه الدهماني اللي هو اي ثينك انه هو ممكن اليوم تجهز فيه اول غرفه. المجمع كله ما زال فيه ولا غرفه، ما فيش ولا غرفه جاهزه، ممكن هو اول واحد ممكن بيجهز. باهي الفلتر الهبه فلتر ايه
اكزامينيشن بيشنت المجمع، لكن مستشفى العيون هو اللي فيها.
اوكي تمام، الدكتور محمد العزيبي صلح لي. المجمع حيكون للفلتر الفلتريشن بتاع البيشنتس. اي حاله سسبكتد مثلا بيديروا لها ريفيرال زي ما تفضل الدكتور سالم بكري. عندنا طبعا هوت لاين، احنا نسيت نقول لك، يعني اي حد عنده كويري بالهوت لاين هذا ويل جايد هيم تو سند هيم تو للمجمع زاويه الدهماني، اللي هو المكان هذا اللي فيه اللجنه العلميه هذه اللي فيها الدكتور باهي. ومن غادي يحول اذا كان يحتاج ايزوليشن في ديبارتمنت في مستشفى العيون. الكرايتيريا طبعا بتاع الايزوليشن والكورنتين ولا الهوسبيتال ايزوليشن ولا وات ايفر، هذه كلها زي ما مكتوبه في الجايد لاينز بتاع ال WHO. باهي، فمين احنا الحالات اللي نشوف فيهم هنا يعني السسبكتد كيس هذه طول يمشوا في الهوم كورنتين، وفي حتى اللي كونفيرمد وقاعدين في الهوم ايزوليشن يعني بروفايد انه هو ان فيري جود كونديشن وما يحتاج اكسجين وما يحتاج any other kind of support ما عدا ممكن بين كيلرز ولا انتيبيوتكس وما يحتاج اكثر من هيك. باهي، لحسن الحظ يعني الحمد لله احنا ما زال ما تسجلتش عندنا سيفير او كريتيكال كيسز. باهي، فاحنا الجايد لاينز بتاعنا على الدبليو اتش او بالامكانيات اللي تسمح لنا هنا بالضبط. فانا بالنسبه لي يعني الحالات اللي نشوف ميل يعني ما همش هلبة هم، لكن قاعد نشوف فيهم ان هم يقعدوا هوم ايزوليشن، لان حتى في المستشفى زي ما تفضل الدكتور بكري والكلام هذا هو اللي مركز عليه هنا، هو از gonna deal with the patient. فهمتني؟ لان صارت حالات بمجرد ما تقول كويري باهي يصير البانيك حتى في الميدكس والباراميدكس نفسهم، فاهم؟ وطبعا هم لانهم not trained ونوت ويل بروتكتد الزوز، يعني ما يوفروا لهمش الفاسيلتيز. مثلا اليوم في مسلم شيفت كامل في الرصاص وفي الاي ان اي ما عندهمش لا جاونز ولا عندهم ماسكس ولا عندهم جلافز، يعني يعطوه السيرجيكال ماسك من الصبح يروح به لليل. وهذا بيشوف حالات يعني خاصه لما في التروما سنتر غادي باهي يشوف الحالات قش مرات، فهمت؟ وتوا ما تعرفش طبعا ما عادش احنا توا ندور فيه الهيستوري اوف ترافل، نحيناه من الكرايتيريا فور دايجنوز اوف سسبكتد كيسز، يعني فهمت؟ تو اي حد سسبكتد بقول سسبكتد هو كان برود ولا لا، لان عندك حالات هنا خلاص ما عادش نعتمدوا عليه الكلام هذا. خالد
تو معناها نفهم منك انا عندكم انتم في طرابلس كلها، نتكلم عن طرابلس المركز، دايرين هوت لاين تليفون والناس تتصل بالتليفون وبعدين توجهوا فيه لمجمع زويد الدهماني، ولو كان مش مجمع زويد الدهماني حاليا ما زال مش واتي حسب ما فهمت انا، اللي الهوت لاين هذاي اللي موجود ببلشت في التلفزيون وببلشت على مستوى على نتكلم على طرابلس المركز تو حاليا ولا؟ لان انت تو اللي بتديرها في طرابلس المركز اللي بتديروه في طرابلس المركز حسب ما نفهم منك انك انتم هذاي نفسها بتديروها كوبي بيست بتديروه في بقيه البلديات، هيك نفهم انا صحيح؟
هذه خاصه البلديات يس
تمام. انا انتم عندكم كوميتي ثانيات زيكم انتم فرعيه، انتم الكوميتي الرئيسيه وعندكم كوميتيز فرعيه في مختلف البلديات، انتم تتواصلوا معها وتاخذوا منها تقرير كل يوم، مزبوط؟
لا ما اخذناش منهم تقارير ما زال، لكن هذا اللي سبوزلي تو بي، يعني هذا اللي المفروض يكون، ما زال ما صارش منه الكلام هذا، ما زال ما فيش جود كوميونيكيشن.
ما فيش جود كوميونيكيشن. الكوميونيكيشن هي المفروض لها علاقه بالفلوس، ما انت لما تقول لا، انت لما تقول انا بنعطيك فلوس، لو كان توتي هو هذاك الوقت حيولي يدير كوميونيكيشن معك، ما هذه واحده من الاشياء اللي بدات تستعملوها والله اعلم، في انكم انتم تقدروا تخلوا الناس تشتغل معكم على الارض تبع الاشياء اللي انتم تحطوها از كمركز مراقبه الامراض ومتابعه الامراض. انا ما نعرفش هذا
معلش
تفضل.
معلش يا خالد سامحني، تو دكتور كمال في هوت لاين ولا ما فيش؟ لو ما فيش هوت لاين، الهوت لاين هذا have to be published، معناها الناس تعرف به، هذه خطوه رقم واحد. لما الناس ما تعرف، معلش سامحني، لما الناس ما تعرفهاش، اول حاجه بيديروها واحد صارت له حراره، شو بيديروا؟ بيحطوه في السياره وبيرفعوه للمستشفى، يصير لك البانيك اللي انت دويت عليه بتاع المركز. فاهم؟ الناس تقدر تعرف رقم التليفون بكل بساطه، فيسبوك، تويتر، كل الليبيين عندهم فيسبوك، ممكن ما عندهمش خبز لكن عندهم فيسبوك، مش عندهم حساب واحد، عندهم حساب واثنين وثلاثه، كويس؟ وعندكم ممكن 12 محطه، منهم الاحرار ومنهم الليبيه الوطنيه، ولكن بحكم انكم انتم NCDC بتديروا بابليكيشن، فمعناها الهوت لاين لابد ينعرف للناس. هذا خطوه رقم واحد، ابسط خطوه. خطوه رقم اثنين، لابد يكون في بروشور، وممكن الجمعيه اللي معانا، ما نعرفش في جمعيه معانا ولا؟
نعم بروجكت هوب يس موجودين.
بروجكت هوب ممكن يساعدوا بانهم يوروا الناس how to do appropriate home quarantining. this is a big problem in Libya. لان انت توا ضرب لك واحد تليفون، معلش سامحني، ضرب لك واحد تليفون قال لك انا عندي فيفر، you قلت له you are suspected case بس stay home. Do you need oxygen؟ انت ازرق مش عارف شنو، داهش ما ادراك. قال لك لا انا مش داهش، انا اموري تمام، لكن انا عندي شويه حراره. باي خذ باراسيتامول وقعمس في الحوش. كلمه قعمس في الحوش هي شنو معناها بالنسبه لي هو ولعيلته؟ هذا حتى هو another protocol have to be developed by the NCDC. كلمه هوم كورنتين بتحطها في حوش، بتحطها في دار، بتحطها في البربوعه البرانيه مع الحمام. مو احنا مثلا برا طرابلس معظم الناس عندهم البربوعه البرانيه في الحمام، هذا حل كويس. كيف العائله تتعامل مع المريض السسبكتد كيس هذا قصه ثانيه. هذا وين المجتمع المدني could help you as يوزع بروشور، يدير نشرات تثقيفيه على الفيسبوك، يحط لقاءات على التلفزيون. احنا as expert panel we could come in، خاصه الدكتور علي العمراني could tell us what is good and what's bad. راوا يا جماعه البلاستيك سيرفيس الفيروس يقعد عليها كذا، راوا لابد تمسحوا بالوراكينه سمبل. الناس ما تبيش حطها في الحوش. باي كلمه حطها في الحوش دي شو معناها؟ يعني هذا انتم لما يجيكم في المستشفى اللي هذا يهرب، باين نحطها في الحوش شو ندير به؟ فابني الموضوع لابد يكون كلام بسيط الناس تقدر تفهمه. هذا يولد طمأنينة. لا كويس. بعدين الجزء اللي بعده باهي، انت حطيت لي ابوي في الحوش، وابوي عنده حراره واحتمال عنده يكون كورونا، واحنا ما عندناش انف تيست في ليبيا. انا نقول لك من توا انا نعرف ان ما عندكمش انف تيست، انا نعرف ان عندكم ممكن ما يتجاوزوش 80 تيست اللي موجودات كلهم كورونا. I know this كويس. نعطيك كلمه اللي بعدها. اوكي، من هو you gonna test؟ المريض اللي بيجيك، نفترض مثلا هذا القرار اللي اخذته انت، تقول انا المريض اللي جاي للمستشفى هذا انا بندير له تيست. كويس. وين المستشفى اللي جاها؟ وين بنرفعوه لما الاكسجين، لما الحاج ولا الحاجه ولا الشاب يكون داهش؟ هذا موضوع ثاني لابد يكون ادفرتايز. راهو تجي للمستشفى، راهو بتجي للمكان الفلاني. لما يجي للمكان الفلاني مين اللي بيجيبه؟ بيجيبه سياره الاسعاف ولا بيجيبه ولده؟ وكان بيجيبه ولده شنو البروكوشن اللي المفروض يديرها؟ هذا المجتمع المدني يكون يساعدك. ما هذا الديتيلز بتاع البروتوكول مهم، لانك كان غلطت في واحده من الديتيلز ما guess what's gonna happen. كنت في مريض واحد عنده فيفر وليت العيله كلها عندها فيفر. كنت في مريض واحد عنده الفيفر ركبته في السياره جابه ولده ولا حتى هو بوزيتيف، ولا مرته ولا اخوه ولا whatever it is ولا بوزيتيف. فالديتيلز هو مهم. وبالنسبه لنا احنا الليبيين للاسف you have to spell it out. يعني you have to tell them exactly what you have to do. ما تقدرش والله يمشي، لان بحكم معرفتي في اخوتي واهلي قليل جدا اللي يقرا، كلهم يحبوا يسمعوا. واحنا الشعب العربي بصفه عامه سمعيين اكثر من قرائيين، فيبوا ديتيلز.
نايس بارك الله فيك دكتور محي، ربي يحفظك. شكرا على التشديد على مساله الببليك اوتريتش، ومفروض يكون في نشر المعلومه. يعني I share with you everyone on the chat في جزئيه في الشات بعض الريسورسز من USCDC تتكلم على مساله how if you are sick or caring for someone with COVID-19 كيف تتصرف، كيف تتحرك، وكيف تدير. اعتقد حتى الليبيان NCDC ممكن بس ترجم الجايد لاين كلها. هذا ممكن حنتواصل حتى مع CDC الامريكي وناخذ منهم يعني كوبي رايتس وغيرها، وبعون الله يعني مسألة الترجمة أعتقد مهمة جدا، وبعدها تعرض في فيديوهات وغيرها. على أي حال طبعا الوقت إذا همنا في مسألة الدسكشن، احنا طرحنا في البداية قلنا ساعة ونص. هل يعني ترون أن مفترض نستمروا لساعتين أو نوقف يعني at this point to conclude؟
أنا في شوية حاجات أوضحها بس تعقيب على كلام الدكتور. في بعض الاشياء بنوضحها. اسمع فيها.
تفضل دكتور.
واضح. بارك الله فيك دكتور. بارك الله فيك دكتور معتيق. الكلام اللي قلته كله ممتاز وهذا هو اللي نبغى. وجزء منه كبير احنا ماشيين عليه. نجول الهوت لاين مثلا، فكره انه هو انك تدير له بابلشنج. احنا عندنا طبعا صفحه الفيس بتاعنا بتاع المركز الخاص هذه، وكل واحد عنده اكسس لها. وعندنا معها صفحه ثانيه حتى هي خاصه ثانيه، حتى هي كل واحد عنده لها اكسس. موضحين الكلام هذا كله دكتور اللي قلت انت، وحاطين الرقم موجود. هو طبعا الرقم تبدل اكثر من مره وهذه مشكله شويه. اخترنا مجموعه ارقام، اعطونا المره الاولى الشركه القابضه، بعدين الشركه الثانيه قالت لا احنا نعطوكم، بعدين جماعه 14 15 قالوا. ففي طبعا شويه سنسيتيفيتي، يعني ممكن احنا نفهموا بعضنا كليبيين وعارفين قصدي شنو قصدي بالسنسيتيفيتي هذه. النقطه الثانيه طبعا البرسبشن بتاع البابليك هنا كنا نعرفوه. يعني تحط له مثلا رقم معين، وتحط له جهه معينه يتصل بها، وتقول له انت لو عندك اي اعراض، في قسم في الانفكشنز ديبارتمنت غادي في مركز طرابلس الطبي، فيه مخصصين جروب تريند وان هم يشوفوا الحالات السسبكتد هذه، وعندهم جايد لاينز يمشوا عليها، يديروا له كلينيكال اكزامينيشن، بعدين ممكن يديروا له فول بلاد كاونت، ممكن يديروا له بعدين سي ار بي لو احتاج. ففي جايد لاين، كلير جايد لاين، والناس تمشي له. الفكره ان الناس طبعا اغلبها تتصل بك على الموبايل فون، لان يا صاحبك يا زميلك يا قريبك يا حد يعرفك هو عارف فيه رقم يشوف فيه غادي، لكن هو بيكلم كامل ولا بيكلم محمد العزيبي لانه يعرفهم، يجيك يقول لك نبي ندير تحليل على طولك. فهمت؟ فالنقطه هذه تيكس تايم باش الكونسبت هذا يمشي في الببليك هذا. فهمت؟ بالنسبه للسمبل بيزك ثينجز هذه اللي نتكلموا عليها، على البيرسونال هايجين، الهاند واشنج، السوشيال ديستانسينج، مثلا السوشيال جاذرينج، هذه كلها نديروا فيها في محاضرات، نطلعوا في التلفزيون نتكلموا، عندنا اعلانات مموله ننزلوا فيها في الفيس، كل شيء موجود. في ناس بارك الله فيها متعاونه حتى بدايه حتى بالبوردز كبيره، يعني فيه الحق يعني جهد، وفيه ناس الحق تخدموا، وهذا كله قبل ميزانيه الدوله طبعا، باش ما يقولوش طرابلس خدمت فلوس احنا ما خدناش. البلديات اللي ممكن ما سمعونيش، البلديات كلها تخدم بجهدها تو، يعني مش طرابلس بس هي للامانه، لان البانيك اول اوفر ذا كانتري، مش في طرابلس بس، خصوصا المناطق الحدوديه والمناطق اللي في الجنوب اللي هم دائما طبعا عندهم لاك اوف ريسورسز، وعندهم مشاكل، وعندهم مشاكل في الكوميونيكيشن وما الى ذلك. فهمت؟ الخطه واضحه زي ما قلت لك يا دكتور، والجايد لاينز واضحات. الفكره انك انت how to implement it, how to enforce people to follow these instructions. يعني انا اخوي نعطيه رقم في الحوش، اخوي نقول له الرقم هذا اتصل به لو عندك مشكله، ما يمشيش للرقم يجي يكلمني انا، هو يعرف الرقم وين. الحاله النشره اللي الدكتور خالد العاقل تكرم وقال عليها، الويب بيج هذه الفيس بيج بتاعنا هذه على طول شغاله، وتنزل في الحالات اب تو ديت. مثلا يقول لك اليوم جونا 9 حالات سسبكتد واندر انفستيجيشن، بعد بساعتين 3 يقول لك 5 طلعوا نيجاتيف، والثانيات قاعدين اوتستاندينج قاعدين نستنوا فيهم. فهمتني؟ في نهايه الامر يعطيك الحوصله في اليوم، يقول لك مثلا معدل الحالات اللي شفناهم 11 حاله، منهم زوز بوزيتيف والباقي طلعات نيجاتيف، وهكذا. يعني في المعلومه في الفيس زي ما قال الدكتور، هو كل واحد تو عنده فيس موجوده في الفيس، وكل واحد شود هاف ذا اكسس، يعني يقدر، يعني يقول لك يجيب لك تليفون يقول لك بالله انت قريت في موقعكم في زوز حالات طلعوا سالبه، مضبوط سالبه، ما عادش عندك بديل اكثر من هيك، بتجاوب تقول له ايه سالبه وخلاص، وتضطر احيانا ما عادش ترد حتى على تليفونك. فكمركز نحكي لك ما زال قاعدين نحاولوا نبذل في قصارى جهدنا ان نوصلوا المعلومه هذه للناس، وان احنا نكونوا ترانسبيرنت وكريدبل في نفس الوقت. لكن البانيك ما زال قاعد اكثر، لان للاسف في بعض الناس يعني بروفيشنال محسوبين علينا نبغى ولا ما نبغوش، يعني فهمت؟ بتوا شيء من الذعر وشيء من الرعب في الوسط في المجتمع نفسه. فهذا كان لي فيري نيجاتيف فيدباك علينا احنا، خصوصا اللي نشتغلوا في الان سي دي سي هنا، فهمت؟ فلازم تعود له وتتكلم وتحكي له. وفي ناس زي ما قلت لك هو يبدا ورد باهي، يعني ما عندهاش حاجه وحتى ما سافرش بكل مجرد انه هو ورد يكح ويبي طول يقول لك نبي يجي يدير تيست. يجون هنا في المركز، راه انا شخصيا يجون هنا يبي يدير تيست، يبي يدير PCR، يقول له انت ما تحتاجش، وتقعد تشرح له وتبسط له في المعلومه. يعني تاخذ معك ياخذ منك وقت، ياخذ منك جهد، باش انت تحاول تقنعه بقدر الامكان ان هذا الموضوع راهو تقدر توصله حتى من غير ما تجيني جاي. تقدر تاخذها حتى من برا في المستشفيات، هذا كانك انت غير مريض، مرضى عاديه يعني كنا نمرض حتى في الايام العاديه. ف it takes some time يعني باهي takes some time to get to the point. الله
انا بوجهه نظري اقترح ان احنا نوجه الاسئله للدكتور علي العمراني بحكم انه هو يعني مختص في مجال الاوبئه والامراض المعديه، ويشتغل في سيتنج ثقافي تقريبا مقارب للوضع في ليبيا، يعني شغله في الخليج العربي تقريبا مجتمع قريب جدا يعني. ف I suggest we go ahead with Q&A ونوجه الاسئله للدكتور علي العمراني في هذا الخصوص يعني.
أنا طبعا بيست في الدوحة، زي ما تفضلت الدوحة مجتمع شرقي، لكن الإمكانيات طبعا الطبية والمادية في الخليج العربي شتان بينها وبين بقية الدول العربية. I could even say probably much better than the US itself. It's a very well resourced healthcare setting. لكن أنا أشترك في الكلام اللي قاله. أنا أعتقد أن الليبيين زي ما شفت حتى هنا عند الخليج العربي، أعتقد أن في تجاوب رائع جدا من العامة general public للببليسيتي وللادفايس. I think ان الكومبلاينس ريس is actually almost impressive. لما تشوف الصور والجي من ليبيا وتتكلم حتى مع الأقارب أغلبهم الحقيقة ملتزمين جدا. وأنا أعتقد أن الأخبار الكويسة اللي كان كامل شاركها معنا أن يعني الحمد لله الوضع لحد الآن not too bad. That's certainly it would have been obvious if it's too bad by now. أنا أعتقد أن a lot of it is due to the success of those efforts, the social distancing. I think the message got clear. أنا أعتقد أن الليبيين كلهم ما يخفاش عنهم أن الظروف الصحية في المستشفيات في ليبيا صعبة، وبالتالي هم يعرفوا أن ما يبوش يكونوا في المستشفى، ما يبوش يكونوا مرضى في الظروف هذه. الحقيقة أن احنا نقدر نتكلم حتى الساعتين جايات كلها على التحديات الموجودة في النظام الصحي في ليبيا، لكن that will not change anything. We all know what's there. لكن لما نشوف الأشياء العملية اللي ممكن فعلا إنجازها وتحقيقها، أنا الحقيقة يعني incredibly impressed بالكلام اللي قاله كامل والمجهود اللي قاعدين يبذلوا فيه. والسؤال هو realistically really how much more can we add؟ إذا كان فيه مثلا أسئلة معينة تتعلق ب clinical management pathways، إذا كان فيه أسئلة تتعلق ب مثلا certain resources like the ones you've just shared now from CDC that you could make easily available for others to just translate to Arabic مثلا.
Well,
I think we would all love to help in any way. Like, beyond that, I think there's hardly much. اللي موجود في دول الخليج هو
to interrupt. When it comes to questions, first of all, just a quick comment on the previous discussion here. When you're talking about a pandemic, it's more than just medicinal management. It's so much, you're talking about it's a way bigger scale. You have to get everyone involved. You've got media involved. You've got security involved. You've got حتى الطاقم الطبي that needs to actually be managed. Not just, they don't need to be good at medicine. They need to be better at management. أعتقد أن this is the key to handle a pandemic. Everyone's comment was very enriching, and the thing is, you cannot say إن تفصيل مش مهم وتفصيل مهم لأن it's all about the details. It's all about mass management. You need to get people to understand it is up to you to save yourself. When you stay at home, you're saving yourself. بعدين when you apply big scale management هي على وضع زي ليبيا, there's a detail everyone is forgetting. إن الناس do not trust hospitals, الناس do not trust government, الناس would rather stay sick at home على إن هي تعرض نفسها إن هي تمشي لمستشفى. فإحنا I think the greatest success we can come out of this conference is to pinpoint focal points we should focus on working on. زي مثلا إن فكرة إنه يكونوا في protocols. البروتوكولز هو مفروض يغطوا كل تفصيل من البروتوكولز موجهة للميديكال ستاف باش يعرفوا يتعاملوا مع الظروف الصعبة اللي they were probably hitting، إن شاء الله لا بس they're probably hitting there، للبروتوكولز اللي حينفذها الشخص نفسه to self quarantine. In general, the thing about corona is that it's hitting a whole lot of people. Not everyone needs to be admitted to a hospital. You're talking about mild cases, critical cases, and يعني the mild cases can just survive it from home. بينما عندك cases معينات هم اللي حيحتاجوا أصلاً يمشوا للمستشفى. To implement an idea this big عند الناس, to grow enough awareness that people go like لا والله I'm tired but I'm not tired enough إننا نمشي للhospital. هذه is a struggle itself. الstruggle الثاني is to explain how to take care of yourself في الحوش, how to self-isolate and how to isolate yourself تحديدا من الناس اللي most likely إن هي to get endangered by the spread of the disease. هذا كله more it's more توعية وإعلام rather than medicine. We need your recommendations in terms of what exactly should we stick to. We need your recommendations in actually outlining المواضيع here, but eventually it's up to the media to deliver this message. I think as a League of Doctors here, أكتر حاجات ممكن ناخدوها in terms of recommendation is 3 focal points اللي هم A, what kind of a management scale أو staff training تعتقدوا إنه هو أكتر حاجة حتكون مهمة. أنا متخيلة إن if the pandemic was to spread حيكون في خطر أكتر من البانيك، حيواجه للناس أكتر من الخطر اللي حيواجه الفيروس itself ولا disease itself. البانيك، الفير. There has been more than one case reported of deaths in Libya, not due to the coronavirus, but due to the panic and fear of the coronavirus. شن ممكن تقدم سواء كانت ال NCDC أو جهة منظمة من توعية أو من protocols أو من تعليم that can control or try and contain البانيك هذا اللي حيسيطر عليه الميديكال staff. حاجة تانية I really would like some input on is the medication للحالات هي. كنا تكلمنا على triage و diagnosis, very important, بس يعني what kind of medicine is most recommended, شن هي الميديسينز اللي مفروض تكون avoided, هل هي available, if not what should we go for. هذا غير المشكلة I think في echo somewhere. هذا غير إن with the lack of equipment we will be thinking of alternatives, but do you recommend or like هل في أصلاً alternatives عليه مثلاً ال huge shortage of masks and gowns, ال huge shortage of ال PPE هدول الدكاترة. What do you recommend we take action باش نحلوا المشاكل اللي حتجينا في المستشفيات؟ لأن if we do not dissect this problem into tabs and then handle them tab by tab, we will end up just going over the problems rather than delivering solutions. We're not here to discuss the problem, we are here to solve it. And as I have mentioned before, it's a very big scale, it's huge. To dissect it and focus on points that we can put input عليها توا, and then maybe we schedule another conference to discuss further information, because I don't think we will cover everything if we proceed بالطريقة here. So Dr. Ali, please, if you can fill me in عليه.
I got your questions. I wrote them down.
Yeah?
I noted down your questions. You don't
yes,
have to repeat
brilliant.
them.
Go ahead. So all yours.
Yeah, I didn't at any point suggest that the details were not important. I guess you misunderstood me. There was no point me going over the same. Pathways are something that needed to be decided by local physicians. I can copy and paste my local protocol, but it would be completely useless to you if you didn't have the same facilities and the same access to the same expert. So you would need to work with a lot of very good local people who could tell you what they could do with what's available, rather than me sitting here and telling you what is the right thing to do. I'm just speaking generally. The medication, which is a very pertinent question, and I'll try to make my answer short because I'm conscious of time. The short message is that there's certainly no evidence-based targeted therapy for SARS-CoV-2, none, including hydroxychloroquine that was touted by Trump. I can't say Allah yahdi, lakin Allah yahdi. The evidence is beyond non-existent. It's actually fabricated. People have questioned the integrity of the research team in France, and I can share papers with you that tell you why this is the case. To try to go around illusioned and disillusioned that there is some kind of effective therapy at present, it just doesn't exist. In a different setting, Libya's healthcare system has different challenges. In a different setting, the right way forward is to recruit every single possible patient into a trial. But if you're not in a position to recruit patients into clinical trials, I would say to you, and this is the result of my experience with COVID, and it's also my experience with MERS-CoV several years ago in Saudi Arabia. Not giving patients anything that is potentially toxic is actually a good thing to do. Unless you know that this potentially toxic product, whatever it is, unless you've got enough reason to believe that it is useful, the best thing to do for those patients is actually keep them safe. The second thing I'd say to you is 80% of patients with COVID will never need any hospitalization. They will never need to go anywhere near a hospital. And if a message is delivered nice and clear to the majority and they receive it and accept it, then you've already done very well. The main risk from those 80% is that they can pass it on to the 20% who could then become a problem. So as long as people know, and along with the existing efforts, they become more aware of what symptoms they need to watch out for. And if they have any of those symptoms, the first thing to do is to self-isolate depending on the means that are available to them. Some people live in mansions, some people live in massive big houses, and they can easily find a place just to go away and hide. لكن في ناس عايشين في شقة 2 or 3 bedrooms with 1 bathroom, 1 kitchen. How are they supposed to deal with that? Now, some of us are trying at individual level to make a contribution through various stages. لو كامل أو زملاء are doing anything to try to explain to people what they need to do in terms of giving them practical solutions and ideas, I'm sure everyone in this forum will be very, very happy to contribute to this and give some practical suggestions and ideas to what one would do if they live in a relatively small household and have suspicious symptoms. So the important thing is for those people not to pass it on to those who may need healthcare. And I'll be very honest, it's a painful thing to say. Like in the 20% who will need hospital care, apart from those who are critically ill, they're probably still better off not being in hospital and still better off, if possible, being treated in an outpatient setting, given antibiotics or whatever. And then you've got 5% or so who will need to be ventilated. And ventilation is a very complex intervention. You could keep a person alive by ventilating, but unfortunately they will die, sadly, within days or weeks because of a ventilation-related event. So unless the whole system tries to minimize down to the 0 if possible, those who may need ventilation, I think all the time and effort spent trying to prevent this, in my opinion, will be time much better spent than time trying to teach people how to ventilate. The truth is you can put someone on a ventilator. We have so many capable people in Libya that can more than ventilate. But how do you prevent all the complications and how do you manage all these complications? That's the real challenge. Equipment and PPE. PPE shortage is a fact in well-developed, extremely well-resourced Western countries. There are images in the media of British nurses in London hospitals wearing garbage bags because they can't get their hands on gowns. I've spoken myself to physicians working in North America, in the US specifically, and they've complained for a lack of gloves. I was a witness to a conversation between 2 US-based doctors. One of them was asking the other if they can post them masks. The fact that PPE shortage is here, it is here. So how can we deal with it? This is where we can suggest some practical solutions. Now, one example is if you're dealing with a suspected or a known COVID patient, you obviously need to be wearing an N95 mask. And there is now very good data from Singapore that says that as long as the mask is not damaged, the person can wear it continuously for the whole shift. They don't need necessarily to change it between patients. So if we were to put together such practical advice based on whatever limited but best evidence available now, then we can help people without diverting their attention to things that are far less likely to be of help. I promised to speak for a short time, but probably spoke more than I wanted to.
No, doctor, please. That was very good.
Dr. Ali, maybe what if we cover a little bit, highlight, because we kind of running out of time, maybe we can highlight a little bit about doctor safety, what procedures we must ensure to guarantee doctors and health professionals who are at risk at this point. Maybe you can share a little bit of that.
Also, if I may add to the same question, how can we set up or get a setup that will prevent the facility from being infected
taken into consideration the lack of negative pressure rooms and other equipment that will probably be out of service?
Okay, so I'll start with the facility because this is relatively more straightforward. So we know for a fact, and we have very good data from Singapore again, of environmental contamination surrounding the bedside area of the patient, the immediate surroundings of the patient. I have two pieces of news in that paper and I can share it with you if you want. The first is that there is extensive contamination in the environment. So therefore there is potential for transmission. However, all the samples that were taken after standard cleaning, using standard cleaning products that are used in hospitals, all those samples were negative. The message is, even if you have a patient with confirmed coronavirus in a hospital, as long as there are efficient cleaning processes, there is very low risk of transmission from the environment. And that is why we haven't seen really any large-scale hospital-based outbreaks so far with this particular coronavirus, whereas it was the hallmark of the previous corona, MERS, and so is SARS. We are not seeing large nosocomial outbreaks now. So normal, good infection control processes. And the second part, which is protecting healthcare workers. Now you can start by saying, I want to provide equipment, but unless you provide proper training with the equipment, you will be again potentially misleading your staff rather than helping them. An example would be simple things like how do they put gloves on and how they take them off, how do they put the gowns on, how do they take them off. They could be increasing their own risks rather than protecting themselves. People who wear N95 masks but never had a fit test would actually never know whether they're protected or not. And that again can be deceiving. So a member of healthcare staff could wear an N95, walk into a high-risk patient, maybe even do a procedure like intubate or suction, thinking that they're protected because they're wearing the right mask. But this mask is not right for them. So you need equipment, but just as important, you need training. You need people to know what they're doing. And some of this can be made available locally. I know there are lots of good people who can do that. And others are trying to do this remotely. 2 days ago, colleagues of mine tried to shoot a video to try to demonstrate how you do fit testing, try to demonstrate how you put PPE on. And I'm sure that there are similar efforts at home. But those are the key messages: training and providing PPE. Providing one but not the other is sometimes more dangerous. Because if I know I haven't got a mask on, I'll probably take more precautions than wearing the wrong mask.
Sweet. Thank you so much. Well, maybe another question regarding medications and their risks. What kind of medications to avoid and other precautions to be taken? Since now حتى في الناس متابعة فينا الآن على اللايف ستريم ممكن احنا نشرحها بالعربي هذه تكون أفضل يعني.
اوكي. ما فيش مشكلة تكلم بالعربي. في الأول كان فيه أشياء نظرية مش أشياء حقيقية علمية، لأنها أشياء نظرية، لأن الفيروس يستخدم أجزاء من الخلية هي نفسها اللي يشتغلوا عليها أنواع معينة من علاجات الضغط ACE receptors. ففيه كان نظريا احتمال أنه ممكن بعض أدوية الضغط والقلب أن هي لو الشخص عنده كورونا فيروس، لو الشخص عنده، مش لأن الشخص يشتبه أو يخاف أنه يدخل في كورونا، لو الشخص عنده، فيه ناس في الأول خافت أنه ممكن يكون أخذ أدوية ضغط معينة يأثر عليهم سلبيا، لكن بعدين تقريبا كل الجمعيات العلمية المتخصصة بدون استثناء أكدوا أن هذا الشيء مليش أي أساس علمي حاليا، وما فيش أي داعي أن أي إنسان يوقف أي علاج قاعد ياخذه بشكل منتظم ومهم بالنسبة لأمراض القلب وأمراض الضغط، مش مطلوب منه يوقف أي شيء. كذلك طلعت إشاعات في مرحلة معينة أن في أدوية معينة مثل الأسبرين والبروفين والباراسيتامول، وفيه ناس طلعت إشاعات أن هذه أشياء مضرة مع كورونا. هذا نفس الشيء كلام مليش أساس بالصحة. فالرسالة باختصار هي أن الإنسان اللي قاعد ياخذ أدوية لأمراض مزمنة لفترة طويلة يستمر عليها ما يقطعهاش إلا إذا هو طبيبه الخاص نصح أنه يوقفها لسبب معين، لكن مش بسبب عام لأنه موجود كورونا. لو احتاج ياخذ باراسيتامول باش يتحكم في الحرارة ينزل الأعراض يساعده في الأعراض ما فيهاش إشكال.
طيب بارك الله فيك. عندنا سؤال أيضا من أخونا محمد عبد الله الصفر، ممكن تشارك معنا يعني سؤالك لو سمحت.
أنا نستأذنكم لحظة. I need to bring the charger لأن الكمبيوتر حيموت. لحظة بس نختفي ونرجع.
طيب مش مشكلة، ممكن نستلموا السؤال من أخونا محمد عبد الله، ممكن نلخصوه وبعدين نسألوه واحد الدكاتره ممكن يجاوب يعني. تفضل اخي محمد.
السلام عليكم.
وعليكم السلام.
وعليكم السلام.
أنا عندي وجهة نظر في القصة هذه كلها. طبعا أنا دكتور سايكاتري يعني مش لا إيميونولوجي ولا أي شيء علاقة بالفايرال يعني. لكن وجهة نظري في الموضوع إن إحنا إذا كنا نديروا نفس اللي يديروه الدول المتقدمة حنعاودوا نفس المشاكل اللي عانوها وحنكونوا أسوأ وضعنا منهم هم. إحنا نفكروا بطريقة أحسن يعني مختلفة نهائي، لأن إحنا نعاودوا في اللي يديروا فيه هم اللي هم ما يقدروش يلحقوا عليه يعني. إحنا إمكانياتنا أسوأ منهم بهذا. وجهة نظري فكرة اللي هي احنا ناخذ سيلكتيف بيرسون ونعرضوه من الفايرال ونحطوه ونعزلوهم ونرجوهم يتعافوا، بعدين الناس هذول هم اللي يقدموا اللي هو هيلث كير للبيشنت تاع الكورونا. مش عارف اذا كان الموضوع هذا ينجح ما ينجحش، هذا ممكن تبقوا معلومه منكم انتم اصلا نسال السؤال هذا بس معلومه تاعي. ولو نجح الموضوع يعني يصبح يعني هيرد اميونيتي بطريقه سيلكتيف، مش طريقه نخليهم الناس يتعرضوا للفيروس سبونتينيوس يعني. هذا السؤال.
اخ محمد حقيقه سؤالك very interesting حقيقه. الاشكال انك لما تقول ان الاشخاص الاصغر سنا اقل احتمالا ان هم يكون عندهم اصابه شديده بكورونا، هذا لا تعني انه ما فيش احتمال انهم يجيهم اصابه شديده. نسبة حوالي 1 إلى 2% من الناس اللي أصغر من 30 سنة ممكن يكون عندهم سيفير كورونا. وأكيد سمعت أنت على الخبر المحزن أن أمس شاب عمره 13 سنة توفى بسبب كورونا في لندن. الشاب هذا ليبي الأصل. فتعريض شخص عمدا لكورونا على أساس أنه تكون عنده مناعة وبالتالي يصبح قادر أنه هو يعالج مرضى بدون خوف، هذه عملية خطيرة جدا. لو الاحتمال الخطورة فيها 1% ولا 2%، هذا يكفي أنه يخليها ethically أخلاقيا صعبة. فأنا قطعا ما ننصحش أبدا أن الإنسان يتعمد أن يعرض نفسه لكورونا على أساس أنه هو حتكون عنده مناعة وبالتالي يقدر يوفر خدمات لغيره، لأن هذا قد يكون انتحار. حتى إن كان نسبته 1 أو 2 أو 3%، ما هو الشيء يعني صحيح. بالعكس، الشيء الصح هو قدر الإمكان ندربوا الناس ونعلموهم أنهم يحموا أنفسهم.
طيب أي سؤال آخر من المشاركين معنا؟
أعتقد نزار جربي واحد من الموجودين معنا عنده سؤال.
تفضل.
الأخ نزار جربي طبيب أعتقد. دكتور نزار.
أيوة دكتور.
أيوة نعم.
جريبي أهلا. كيف حالك دكتور عصام؟ كيف حالكم كلكم؟
حياك الله، أهلا بكم.
الله يسلمك ويبارك فيك. هو تعليق اكثر من انه هو سؤال بس للدكتور كمال. طبعا بارك الله فيه على كل الجهود للشباب الليبيين والاطباء اللي قاعدين يديروا فيه في ليبيا. لكن بس طبعا هي طبعا نقطه تعرضوا لها في السابق، بس حبيت ان اي ستريس اون ات كجراح. يعني من صعب تخلي الجراح يقعمس في الحوش تقول له ما تخدمش، لكن بالامكانيات المحدوده بالذات اللي موجوده في ليبيا اعتقد ان المفروض واحده من الاشياء دكتور كمال ان المفروض ممكن طبعا انت تبي دعم من سواء كان القيادات الصحيه ولا السياسيه في الدوله، ان فعلا الريسورسز اللي في ليبيا لانها ليميتد، سواء كان البي بي اي والا الاي سي يو رومز، المفروض ان توقف الالكتيف سيرجريز في ليبيا كلها بالكامل على الاقل لحد to get over this. بس كنت هذه حبيت نأكد عليها النقطة مرة ثانية بس. بارك الله فيكم.
بس للمشاهدين يعني elective surgeries هذه لا علاقة بالعمليات الاعتيادية يعني.
يعني لو أنا بس نقول لك على مثلا خبرة شخصية بالمستشفى اللي أنا طبعا جراح colorectal surgeon ونشتغل في وست فيرجينيا يونيفرسيتي. فمثلا يعني من اسبوعين فاتوا كانت الالكتيف سيرجري، من اسبوعين فاتوا هي البناين، يعني مثلا هيرنيا جول بلادر اشياء زي هي عرفت بلاستيك سيرجري، هذا كله هذا كان من اسبوعين التعريف الالكتيف سيرجري. بعدين من اسبوع فات حتى الكانسر ولا الكتيف سيرجري. يعني لو المريض عنده كانسر وهي كان ويت مثلا يعني لو ريسك، في الاول طبعا هم قالوا لو ريسك، جت من الامريكان كولج اوف سيرجن وكانت كونفيوزنج، ما عرفناش معناها لو ريسك وهاي ريسك. ففي الاول كانت لو ريسك وكانت مش واضحه، بعدين على اساس انه يا اما مثلا يكون بري كانسر والا فيري ايرلي كانسر، والمريض كان ويت اتس سيف تو ويت فور 2 ويكس او 3 ويكس، هذا كله يلغى. وبعدين طورت، وما نعرفش طبعا دكتور عصام ما نعرفش خبرته في واشنطن دي سي ولا محي الدين في سنسناري، لكن بعدين احنا توا وصلنا حاليا توا المستشفى عندها centralized committee هي اللي تقرر، ما عادش حتى الجراح يقرر شنو هي الحاله اللي تنخدم والحاله اللي ما تنخدمش. فاللي توا واضح اللي هي life saving procedures او you have to operate otherwise you will cause harm، يعني short term harm يعني. فمثلا مثلا bowel obstruction perforation اشياء زي هي، والباقي كلها المستشفى بالكامل واقفه، مع ان هنا الامكانيات زي ما انت تعرف في امريكا افضل من ليبيا بكثير. لكن مع هذا شوف قداش الاجريسيف ستيبس اللي ياخذوا فيها هنا باش يحاولوا يحافظوا على الريسورسز هي كلها يعني not get utilized now وبعدين يقعدوا short handed في المستقبل. فبس يعني في ليبيا بحكم انه طبعا الناس كلها تتكلم عن امكانيات، لان بعدين لا قدر الله لو صار اوت بريك اصلا ما فيش حتى في السوق العالميه من راح يبيع لهم اساسا المواد هي هذه من جانب. ومن جانب ثاني ما عادش في زي زمان لما حد يمرض يمشي لتونس، ما عادش في ولا دوله حتستقبله، فيبي يعالجوه غادي يا بتموت. فبس زي هي يحطوها في البال. اعتقد انها لازم تكون جزء، لكن طبعا هذه السي دي سي بروحها مش حيقدر يدير شيء، هذه تبي اراده سياسيه من دوله تفرضها. زي مثلا احنا الجفرنر بتاعنا بتاع الولايه بتاعنا يعني صدر قانون ان الالكتيف سيرجريز في الولايه كلها توقف بالكامل، قانون من رئيس الولايه، اصبحت ما عادش من المستشفى بس. فبس اشياء زي هي. بارك الله فيك.
بارك الله فيك دكتور نزار.
Just to explain something very important. Decisions are here absolutely 100% not transferable. لأنك تعتمد على where are you in the exponential phase أو لا of an epidemic ولا pandemic، ويعتمد how are you managing your existing resources، ويعتمد على very careful risk assessment of what is the risk of delaying a procedure versus doing it now، وتحتاج نظام مركزي هو اللي يقرر. أنت مثلا في US quite rightly أكثر من مرة refer to مثلا the American College of Surgeons، refer to CDC، refer to your government، يكون في central decision making. That is absolutely the right thing to do. فهذه حاجة اللي كامل الزملاء يحتاجوا إنه يفكروا هم وين توا حاليا من الابيديميك، وهم دو دايرين لي أصلا مونت to create capacity في المستشفيات ويجيبوا المرضى ولا لا يبغوا يقعدوا في الحوش. فهم they have to make decisions that could be entirely completely. في قطر مثلا وقفوا جزء من الالكتيف سيرجري لكن خلوا جزء ثاني. لكن شنو عندهم امكانيات تكفيهم انه يفتحوا زوز مباني مستشفيات كامله جديده عمرهم ما فتحوهم قبل، وخصصوهم تخصيص لمرضى كورونا. ثم فتحوا مستشفيات مؤقته فيها expandable capacity، فتحوا 200 ويقدروا يخلوهم 400، يقدروا يخلوهم 800، يقدروا يخلوهم. They're doing all this so they can protect their capacity. فكل دولة تقرر باللي عندها. ففيه دول توقف وفي دول تستمر. في دول لو وقفت السيرجري الناس حيموتوا بكومبليكيشنز ثانية. فصعب الترانسفير that experience. I'm just saying you have to be careful.
So to echo everything Ali said, there is a lot of news out there. I cannot emphasize whatever he said. I try to convince my wife that NSAID have nothing to do with coronavirus, like Brufen or Advil and I'm getting a resistance from her. So I cannot echo legal Ali. There is no proof or disproof for anti-malaria medications to help or not help. It's all kind of made up by French, believed by Trump, and he publicized it. Paracetamol versus Advair versus NSAID. I'm not sure anybody have any proof or disapprove for any difference. The more important thing for the منظمة رحمة اسمها، أنا سامحني معلش راحت علي
ممكن
اللي في ليبيا ولا اللي في الدي سي؟
اللي في ليبيا
ممكن
منظمة ممكن they can join the NCDC ويشتغلوا مع الماب اللي بتحطها ال NCDC. Without a map, without خريطة من ال NCDC احنا صعب علينا جدا ان احنا نساعد. loss of equipment انا بنقول لك اليوم انا نستخدم في ال N95 ماسك طلع ريبورت في الولاية اللي أنا فيها you could use it for 5 days. And not only that, you could reprocess it. mean after you finish تعرف احنا يعطونا الماسك توقع عليه ورقة ترجع الماسك بعد 5 أيام يعطوك واحد ثاني ياخذوا الماسك ويديروا له ريبروسس. مش معناه هو هذا الصحراء، معناه هذا هو اللي موجود عندي في اوهايو، يختلف عن اللي موجود في وست فرجينيا، يختلف عن اللي موجود عند هشام في اريزونا، يختلف عن اللي موجود. ف without guideline from the NCDC بتاع ليبيا شن انتوا تبوا تديروا، احنا نقدروا نساعدوا على اللي انتوا تبوا تديروه. انا نقدر نعطيك خرائط ما لا نهايه، لكن it's not gonna work with you لان مش موجود على الارض. انا نقدر نساعد في تدريب الدكاتره، انا نقدر نساعد نحط لك فيديوز how to glove and deglove. It's on the CDC website. There is a nice video how to glove and deglove. لكن انا ما نعرفش هل انا البضاعه اللي موجوده في CDC في امريكا هي نفس البضاعه اللي موجوده في ليبيا. الماسك اللي انتم جبتوهم اللي delivered 2-3 days ago, they came from Germany. They don't need to be fitted. As a matter of fact, the mask you brought اللي وراهم الدكتور في المستشفى المركزي هذوما للجنرال public، هذوما not to the physician. There is a different one for physician from the same company. So those details have to be known and monitored. The only one you need one خريطة واحدة باش المجتمع يصدق الكلام اللي انت تقول فيه، ما يطلعش بتاع ال NCDC يقول كلام ووزير الصحة يقول كلام ووكيل وزير الصحة يقول كلام و there is multiple direction. So without you guys putting a map, we could talk until tomorrow. We could give advice to ممكن مثلا من الكلام هذا كله جمعيات الأخوة اللي في المجتمع المدني they could help by spreading the word. There is a hotline. There is a doctor gonna receive your phone call. He will give you a clear instruction. وبعدين مش هيك بس، الدكاترة اللي بيستقبلوا المكالمة ممكن يكون في clear protocol who will be referred back to the hospital and who's gonna stay at home. هذا هشام ممكن يساعدنا شنو هو البروتوكول اللي نقدروا نستخدموه. احنا توا all we know and understand that there is no cure or medications or something gonna fix this problem. We all understand that. We all agree with the basic in Libya. Buying a 500 ventilator is not gonna help you. What's gonna help you is public educations, hotline, some way of some way, which I really do not know what's the right way. It's depending on the of triaging who should go to the isolating center and who should stay at home. So we know those concepts is the 3-4 concept that we should focus on. Now, educating people at home is important, and educated physician, depending on what's available there, is important. أنا نقول لك في أمريكا we don't, or أنا المستشفى اللي فيها عندي 6 cases, we don't use the white full gown. We only use the yellow gown and gloves. Yellow gown, gloves, and we use a shield and N95. And I was fitted for N95. So I went downstairs, I sat in the machine, and they try it, and they did all of that. هذا ماشي معايا هنا في أوهايو. Or this is the recommendation here. What is the recommendation بتاع NCDC في ليبيا? With what's available there. كان أنت unfortunately, I could help tell you what I do here, but it's not gonna work because أنا نعرف اللي غادي مش اللي هنا. أنا نمشي كل سنة يعني I spend significant amount of in multiple hospitals. I know what's there. شكرا.
بارك الله.
معلش ممكن نرد على تعليق الدكتور علي لو في وقت.
والله تقريبا احنا عندنا ممكن 5 دقائق وبعدها لازم we have to conclude يعني.
اوكي في دقيقه. انا صراحه يعني نختلف شوي مع الدكتور علي في النقطه اللي قالها ان مثلا اللي يندار في امريكا من ناحيه المحافظه على الامكانيات اللي موجوده في المستشفى بعدم اجراء عمليات يعني الكتف، انه من صعب في ليبيا بحكم ان ما فيش سنترلايزد يعني ما فيش جهه مركزيه تقدر تسيطر على الوضع. اختلف معه في النقطه هي ليش؟ لان اعتقد ليبيا في احوج اكثر من امريكا بان الاشياء هي لازم يعني لازم it has to be implemented في ليبيا. واعتقد ان لما مثلا النقطه نتاعها كانت من اللي حياخذ القرار، من اللي حيقول انه المريض هذا يتاخر، الجراح. يعني الجراحين نفسهم في ليبيا هم اللي ياخذوا القرار، مش حياخذه اداري او حتاخذه جهه سياسيه في الدوله. الجهه السياسيه في الدوله بس تدعم ان الاشياء، ان العمليات الكتف لازم توقف في البلاد بحكم ان الامكانيات اللي عندنا محدوده ما نبوش نستهلكوها. لكن الجراحين كل جراح هو اللي بيحدد، هو بيقول ان المريض هو يقدر يستنى شهر بس على الاقل لمده شهر، وبعد شهر رياسس اذا كان، والامرجنسي has to be taken care of. فبس يعني هذه توضيح. السلام عليكم.
وعليكم السلام ورحمه الله. معناها ايضا نوصل لمساله الريكومنديشنز. احنا حاولنا كيف نغطوا يعني facility management and staff training, the supply management and recruitment. مرينا على مساله diagnosis والتريتمنت، وايضا الميديكيشنز والبريكوشنز. ايضا تكلمنا على مساله النيدد equipments والاسنشلز المفروض تكون موجوده في ليبيا، وغطينا ايضا مساله دكتور سيفتي والتريننج والحاجه الى ذلك. وحقيقه في نهايه النقاش ناقشنا مساله what can we learn from the US response، وشنو هي الحاجات اللي ممكن احنا to avoid، يعني الاشياء اللي تم اتخاذها في امريكا احنا ممكن اخطاء او النواقص اللي تمت اتخاذها في امريكا ممكن احنا نتجاوزوها او to avoid. What if we go through like closing statements from the panelists وبعدها يعني conclude يعني شنو رايكم؟
I don't know if we have time for that. لكن I guess the main things that I believe are relative to Libya هيكون proper use of PPE and the rational use of PPE. A great point من Dr. Ali was that standard cleaning procedure would give some form of guarantee to stop the spreading, or إن هي مش البيئة environment هو will not spread the virus. That's something that we can implement in Libya. We are trying to organize trainings. We are trying to reach to the authorities to aid in spreading knowledge and spreading awareness to the public and to health workers, to be able to give them the confidence and the proper knowledge to make informed decisions of when to work, when not to work. Also to the public, when to come to a hospital, when not to come to a hospital. I believe we are capable of producing a campaign that will effectively reach the public, and it will inform them of when to call and when not to call. And after calling, what to do, the proper guidelines of what to do at your home, how to protect your family from possibly catching the infection from you. We have the capabilities. Unfortunately, what we need is proper organization. We need to have official collaboration with the NCDC, with the Ministry of Health, in order to be able to effectively reach the people and effectively produce training programs that will be adhered to, and produce protocols that will be adhered to not only here in central Tripoli, but across the whole country. I hope that if any of the panelists have any comment on these topics, please say what you have to say.
طيب احنا let's go ahead maybe to highlight to the recent the last remarks that were shared with us and go ahead with closing statement. Dr. Isam, do you have any closing statements?
Yeah, I mean, I just want to highlight طبعا ابتداء نشكر كل الأفاضل الأخوة الدكاترة والباقي أعضاء الفريق يعني المشاركة. حقيقة كان نقاش غني ومثري وأعتقد فيه جوانب كثيرة غطيت. ممكن قد يكون من أهم القضايا إنه إحنا نحدد لأنفسنا ما هي الخطوات التي نستطيع أن نقوم بها إحنا كفريق طبي خارج ليبيا، وكيف نتواصل مع القائمين على الجهود الطيبة هناك في ليبيا اللي هي طبية. كثير من القضايا أثيرت. أنا أحسب إنه الأكشنبل آيتمز يعني من القضايا اللي إحنا نقدر نعملها في الخارج، ذكرنا موضوع الخط الطوارئ يعني الهوت لاين اللي ممكن يكون متوفر على مدار الساعة ويشرف عليه مجموعة من الأطباء المتخصصين، يعني يكونوا اون كول بيسكلي وذ اس، بحيث يكونوا مجال للاستشاره مع اي طبيب يطلب التشاور معهم في القضايا المحدده اللي ممكن يثيرها، اذا كان طبيب اخصائي تنفس، اذا كان طبيب امراض معديه، اذا كان طبيب صحه عامه، يعني فيما يتعلق بذلك. الامر الثاني اللي ممكن احنا نشتغل عليه كاطباء خارج ليبيا هو التعاون مع الجهات اللي عندها برامج تطويريه سواء تدريبيه او سواء معلوماتيه بصفه عامه، ممكن احنا نطورها سواء كانت من خلال الترجمه والتاهيل، وممكن نكون جزء من تطبيقها اذا كنا احنا قادرين على التعاطي مباشره مع الجهات اللي ذكروا الاخ اللي اجى سيد كريس هذا من هوب، وذكر موضوع البراون يونيفرسيتي والتريننج بروجرامز وغيرها. لو طورت هذه البرامج حتى عن طريق WHO وغيرها، احنا بهذا نزيد الكباسيتي بتاع الاطراف في ليبيا انها تصل الى اكبر عدد من الناس لتدريبها وتطوير قدراتها على الاستيعاب. خارج هذه الاكشنبل ايتمز هنالك فقط موضوع النصيحه والمشوره. هذه طبعا تتطلب وضوح خطه من الطرف الليبي، تتطلب قنوات اتصال وادوات. احنا ان شاء الله نتعاون مع الاخوه في ممكن ليس فقط في تحديد الاليات اللي من خلالها يتم التواصل، ولكن ايضا تطوير المواضيع او تطوير الهايلايت يعني الهيدلاينز اللي ممكن احنا نجتهد فيها، ويمكن التواصل حتى مع بعض الخبراء يعني بطريق مباشر تحديدا، مش لازم كله من خلال اجتماعات كبيره. يعني اذا كان الاخ علي العمراني الله يذكره بالخير او الاخ هشام البوسيفي او غيره قادرين على انهم يخصصوا وقت للتواصل مع الاخوه زي الدكتور كامل الله يذكره بالخير والاخوه في مركز المكافحه الامراض، يعني ممكن تطوير اليات تعين في تنفيذ بعض المقترحات بالاضافه الى المتابعه الكامله. وان شاء الله نعود مره اخرى في برنامج يكون مخصص تحديدا للتعاطي مع بعض النجاحات والمعطيات اللي تخرج من هذا البرنامج. وشكرا لكم جميعا مرة ثانية.
بارك الله فيك دكتور عصام، وشكرا جزيلا على your remarks. دكتور محي الدين او احد البانلست، هل عندكم اي closing statements؟
خي مصدق
انا معلش
يا هشام سامحني،
دكتور هشام. نعم
سطر واحد بس يا هشام.
تفضل.
اعتقد لنتفق عليه كلنا جميعا ان اهم شيء الان هو الالتزام بالعدم الازدحام، العزل. الاطباء كيف دكتور علي تفضل كيف يحافظوا على نفسهم في هالبيئه، طريقه التنظيف وشروط العزل في المنزل. هذا الميل اللي ممكن اللي يقدر يركز عليه اعلاميا الاخوه علاء الدين والجماعه من ناحيه ان الببليك يبدا اوير اكثر، مع انه هو ملتزم الى حد الان، وان هذا استمرار الالتزام هو اللي حيمنعنا من الكوارث اللي صارت في بعض الدول المحيطه. بس هذا اللي حبيت ناكد عليه. شكرا جزيلا لكم جميعا.
شكرا عزيزي. دكتور هشام.
بارك الله فيك. شكرا. انا نبي نعقب على شيء واحد، انا سعيد جدا بالخطه اللي موجوده واللي حاول المركز الوطني لمكافحه الامراض انه يضعها، موضوع الهات لاين. بس نبي ناكد على نقطه واحده، انه هو الهات لاينز المفروض انه يكون عشرات من الهات لاينز، يعني الخطوط الساخنه هذه مش خط واحد، تكون عشرات من الارقام وتكون موجوده، لانك انت تتعامل مع عندك 7 مليون نسمه، هذول ممكن يعني 3000 يمرضوا لك في خلال شهر او اقل، وبالتالي انت تبي، وفي ناس ممكن حتى عندها اعراض مشابهه لكن ما عندهاش الكوفيد 19، فانت تحتاج الى خطوط ساخنه عديده مش خط واحد فقط. هذا اول تعقيب. التعقيب الثاني، انت بكري ذكرت على حاله، قلت انا عندي حاله انه هو عنده فيفر وممكن some respiratory symptoms plus you have a positive CT scan. انا نقول لك ان انت ما عادش تستنى شيء ثاني، الحاله هذيك يعني قطعا هو بالنسبه لليبيا ممكن في مكان ثاني يحتاج انه يدير further testing، بس في ليبيا الحاله ذيك قطعا هي COVID-19 و should be managed this way. حتى لو درت التست وطلع negative, I would not take the result of that test. I would treat that case as a COVID-19. وبارك الله فيك، شكرا جزيلا.
شكرا دكتور هشام. اي remarks من الاخوه المشاركين معنا؟ طيب بارك الله فيكم وشكرا جزيلا على المشاركه معنا اليوم. تقريبا غطينا اكثر من جانب، والحمد لله يعني خرجنا ببعض التوصيات نحاولوا نبلوروها في recommendations او documents او مستند قد يقدم للمركز الوطني لل NCDC يعني في ليبيا، ونحاول ان تكون هذه حلقه في سلسله من نقاشات التي تساعد يعني اهلنا في ليبيا واهلنا بالخارج بحيث ان يتواصلوا ويشاركوا خبراتهم وتوصياتهم يعني بشكل مستمر بشكل بعون الله يكون يعني في ديمومه في هذا الشغل. شكرا جزيلا لفريق ممكن. Thank you so much for putting this together and your hard work and making this happen. بارك الله فيك دكتور محي ودكتور عصام ودكتور خالد ودكتور علي العمراني وكل المشاركين معنا من كل المناطق. احنا ان شاء الله نجهزوا documents بعون الله بعد هذه المكالمه ونوزعها على الجميع. ايضا نقطه اخيره، في الشات وزعنا يعني شاركت معكم بعض الروابط اللي فيها شويه ريسورسز وشويه معلومات يعني من CDC الامريكي، وان شاء الله المره الجايه يكون في تواصل مباشر بيننا وبينهم، ونحاول كنا نجيبهم معنا ايضا بحيث ان نتبادلوا التوصيات والدروس المستفاده من ليبيا وامريكا. بارك الله فيكم ومشكورين جدا و stay home and stay safe. Thank you.
إن شاء الله.
Thank you everybody. Thank you.
السلام عليكم.
All right, thank you very much.
شكرا.